Good morning, everyone. Shoot, I just realized I was like, why? Okay. Did you have a question? I'm sorry, guys. I had my volume turned all the way down and did not realize it. Good morning, Brandon. Got a couple minutes here. How was your guys' weekend?
It was busy, but it was good.
Good. Yeah, I'm in the process of moving, so I feel like I never get a break right now.
Pretty good weekend. Pretty busy. We're still missing just a couple people, so I'm gonna give them just another minute here, and then we'll get started because we got lots to cover, and I don't want to mess around too long. So while we're waiting, couple of things. The first is Miss Angie just texted me this morning to let me know that they got the thing fixed where you guys can now upload everything into Brightspace for your VSIMS assignment. She said, let me just pull it up. She goes, there's a place to upload your guided reflection questions and documentation for both of the VSIMs. So I know a lot of people emailed their reflection to me, and that's fine. If you can go back and upload it, I will check. I'm making myself a note right now that I am going to check the Brightspace due date where they make sure that you guys can get in there and upload it. Obviously, it won't be considered late because you couldn't get it done. But it's fixed now.
Excuse me, Miss Brenda.
Yes.
Where exactly do we have space for it to upload?
What's that?
Where is exactly? Is it under clinical paperwork? Or where
No,
is it?
I think it'll probably be with the VSIM. I haven't got in there and looked because she just sent that to me.
Okay.
That text. So I don't know. I'll get into Brightspace after lecture today
Okay.
and I can, hold on, be some reflection and documentation. Due date, location. And then I'll put out an announcement in Brightspace. Okay. So we'll put out an announcement in Brightspace.
Okay.
And then I'll let you guys know. I'll make sure that the due date is correct and that that I tell you guys where it's located at. Okay? Sound like a plan?
Yes.
All right. All right. So for those that I just let in, I was just telling everybody that there is a place now for you to upload your documentation and guided reflection questions in Brightspace. So after lecture, I'm going to go look. I'm going to make sure that I adjust the due date on those to make sure that you can upload it. And obviously, it won't be considered late because there wasn't a place for you to upload it. I'm not going to consider it late. And I know a lot of you emailed it to me, but if you could attach it in Brightspace, that would be great. And then I will let you know in the announcement where to find it, where you need to upload. And then real quick, I wanted to let you guys know, actually, we're gonna finish the rhythm strips. That's what I want to focus on. I know this is a big thing for everybody. I know you guys are stressed about this. I know Miss Angie went over, I think the clinical instructors went over these kind of like in person with you guys in clinical. Did that help? Like seeing it in real life? Okay, I got one thumbs up. Okay. Anybody feel like it didn't help? Okay. So I do want to get started because there's a lot to cover here. So we left off, let me share my screen. Let's get this done. All right. Can you guys see my screen? The PowerPoint?
Yes.
Okay, beautiful. Thank you. Okay, so we remember, I'm going to like really briefly talk about this again, that we went over atrial rhythm problems, atrial fib versus atrial flutter. Okay. So atrial fibrillation, remember, is the one where they're quivering. Oops, that's not what I don't want to draw over it there. Okay. Where they're like the atria are actually quivering, okay? Or what we call fibbing, fibrillating, okay? And that's the one that is going to be very irregular. You can see that between here and here is much shorter than between here and here. They're not regular at all. If your heart rate is 100 or less, it's going to be controlled, AFib. If it's over 100, it is uncontrolled AFib. Because you can't pick out a specific P wave, okay? You put your P wave as unidentifiable, and if you don't have a P wave, you can't measure a PR interval, right? Because you have to have the beginning of the P wave to measure that. So you're going to put unmeasurable. You would measure your QRS, and this is very narrow, but it looks like it's about 2 squares. So 0.08 is what I would guess, okay? And your rhythm is irregular. Everybody with me on AFib? Okay. A flutter has those sawtooth, they're very uniform. The P waves look the same, although there's more of them than there should be. But you can see how those P waves, right, see how those P waves look very similar to each other? And so there's more rhythm here. Sometimes your A flutter can actually be, but see how those P waves all look very similar. Unlike in here, your P waves don't look the same when we're over here. The P waves don't look the same. Okay, these P waves do. And so there are times that atrial flutter can actually be a regular rhythm also, because the AV node, which is our gatekeeper, is only letting every third electrical impulse through. So you'll see 3 P waves and a QRS, and 3 P waves and a QRS, and 3 P waves and a QRS. Okay, so because of that, it can be regular. Your rhythm can be regular or irregular. Now, your P wave, you're going to describe as sawtooth flutter waves. Okay? We cannot measure a PR interval because which P wave are you going to choose to measure that PR interval? Right? Because there's more than one P wave, we really don't know which one is coming from the SA node, and that's the one we need to be measuring. And we don't know which of these that is. So it's unmeasurable. And then you will measure your QRS. And that looks like, it looks normal. Again, if we had, I would print better paper, but you can look in there. It looks like it's about 1.5, which would be 0.06. Okay. So that's normal, right? And the other thing, somebody had asked me, when we're measuring the QRS, the PR interval, those type of things, those two things, typically, so if every QRS looks pretty much the same, you just pick one. of those QRSs to measure, that's your measure. Okay? If every one of your P interval, your P waves looks about the same in front of your QRS, looks about the same, then you just pick one and measure it, and that's the measurement you're going to give. You do not have to measure each and every complex. Now, there's going to be one time in particular that we are going to measure different PR intervals, and we will talk about that. Okay? You'll know. I'll tell you when you have to do that. But other than that, you're going to pick one complex, measure your PR interval, measure your QRS. Okay? I just wanted to clarify that because I wanted to make sure you guys know you don't have to measure every single one. Okay? So, what are some causes? I think we kind of talked about this, but I'm going to go over it again. Coronary artery disease, heart failure, hypertension, open heart surgery, because we just mess with that heart, COPD, a myocardial infarction or MI. Okay. These are things that can cause this, these rhythms. And I think I told you guys atrial fibrillation is way more common than atrial flutter. Symptoms can be palpitation, shortness of breath, chest pain, anxiety, dizziness, but they can also be completely asymptomatic. So they could be in one of these two rhythms, and especially if their heart rate's under 100, they may never know. Okay. And then remember, we talked about this. Cardioversion is that lighter shock that has to be synced with the QRS complex. So you have to be in synced mode on the defibrillator. Okay. If your patient is stable, maybe ask for something to help them like relax a little bit. This is going to hurt a little, but it has to be done. If your patient's unstable, we don't have time for that. Okay. A little uncomfortability is better than going into cardiac arrest. So, and then medications, things like beta blockers, metoprolol is commonly used because it controls rate. Okay, metoprolol isn't necessarily used to change the rhythm. It is used to control rate. And the same goes with calcium channel blockers, like cardizem. Okay, so, oh, I forgot I meant annotate. Okay, sorry. I'm moving this up. Okay, so calcium channel blockers like cardizem. Now, the medications that we want to give to help change the actual rhythm are antiarrhythmics. Okay, and these are things like amiodarone, digoxin. We've talked about these before, right? So digoxin, what are the things we have to worry about? What are two major things we have to worry about with digoxin?
Toxicity.
Toxicity. And what is a sign of toxicity?
The yellow aura.
Can be, yeah. What do we have to do before we give digoxin?
Check
The
their
low
heart rate.
potassium.
That's
Yeah,
right.
we need to check their heart rate. So we want to make sure that their heart rate's above what?
60.
There we go. Bradycardia is a sign of digoxin toxicity. And you're right. So, and potassium is an issue also. So we need to keep a close eye on their potassium levels. Whoever said that, I did hear you and you are correct. Okay. And then blood thinners. And the reason we do blood thinners, I remember I talked about if my atria are just quivering, I'm not pushing all the blood out, and blood clots. And so they have a really high chance of ending up with a pulmonary embolism or with a stroke, anything like that. So it's really important that we watch for those signs and symptoms, and we do patient education about blood thinners. What are blood precautions? I'm a patient, I'm going on blood thinners for the first time. What are you going to tell me? Teach me.
Use an electric razor or a soft toothbrush.
Very good. What else?
Avoid aspirin.
Mm-hmm. Aspirin and what else? There's another class of drugs.
NSAID.
NSAID, yep. So they need to avoid NSAIDs, so they need to use acetaminophen or Tylenol for pain control, not ibuprofen, naproxen, anything like that. Aleve, this is the other name. So make sure that they know that. What else? So look at me. You just put me on blood thinners.
If it's like warfarin, we talk about K, vitamin K.
Okay. Yep. Diet. And the importance of maintaining their blood draws. Can I go get a tattoo?
No.
Probably not in the beginning. All right. We need to avoid those type of things. What if I play soccer? I'm in no, I'm not going to give an over whatever soccer league. Okay. I'm not telling you my age. So I like to play soccer. What are you going to tell me about that?
Maybe precaution like helmets.
So
Avoid.
should I still play soccer right now?
No.
No. No contact, no impacts, no contact sports. Okay. Nothing that could potentially cause any type of tissue injury. One last thing. So I'm on blood thinners and I'm driving my car and I get in an accident and I'm not conscious. How are they going to know I'm on a blood thinner?
Bracelets.
There we go. Some type of alert, right? You need to have some type of meta alert on them so that it is known that they are on a blood thinner if they are not able to speak for themselves. All right, good job.
So I have a question, please. Is it the cause of a AFib and A flutter? Are they the same causes?
No,
So,
the
okay.
causes are the same for both of them.
Okay, that's what I wanted to know. So the causes and symptoms and treatments are the same.
Yes,
Okay,
exactly.
thank you.
You're welcome. Absolutely. I will say people who have A flutter may not go on blood thinners because you are getting contractions of the atria, but how good of a contraction? Maybe not as much, but that's the only thing that would be different is you may not see patients go on blood thinners for A flutter.
Okay, thanks.
Yeah, no problem. All right. So junctional rhythms. All right, so I'm going to talk about this very briefly. Don't even bother writing stuff down because I will not test you on junctional rhythms. You will not see a junctional rhythm on your exam or on your final, okay? That is a promise. No junctionals. But basically what a junctional rhythm is, this is when the SA node fails. And so the heart rate comes from the AV node. Remember we talked about, like, if your SA node doesn't work, your AV node will pick up, and your inherent rate of the AV node is 40 to 60. And that's why when you look at this, you will see regular junctional rhythm has a heart rate between 40 to 60, okay? Right here. If it's below 40, then it's called bradycardia, junctional bradycardia, okay? If your heart rate is above 60, it's called accelerated bradycardia. Or I'm not, sorry, accelerate, I'm trying to do too many things at once. Accelerated junctional, okay? So that is a difference. So you have your rates, but what the difference between bradycardia is normally below 60, but because it's an AV node, is its inherent rate isn't above 60. So if it's below 40, it's a bradycardia, okay? Your rhythm is still going to be regular because your AV node will throw out a regular rhythm at a rate of 40 to 60. Okay? Your P waves are either absent or inverted. What inverted means is that they will dip down. So when you see the P wave, instead of going up like this, it will go down like this. So it dips down or is inverted. Okay. And then because if you don't have a P wave, your PR interval is unmeasurable, but your QRS is still going to be narrow. That even looks like it's like, again, 0.0 or 0.06. Okay. So again, you guys don't need to identify a junctional rhythm. It will not, that strip will not be on your test. The most common cause of junctional rhythms, I will have you know this. This is the one thing I want you to know, is digoxin toxicity is the most common cause of junctional rhythms. Okay. But then you can have the other things like sinus node dysfunction. Sometimes the sinus node just doesn't function like it's supposed to anymore. Cardiac surgery, a myocardial infarction, carditis, okay, which is an inflammation of the heart. These type of things can cause these junctional rhythms. Again, what I want you to know is the most common cause of junctional rhythms is digoxin toxicity. So if your patient's in a junctional rhythm and they take digoxin, what is the first thing we're going to do?
Stop the
Check.
digoxin.
Just
What's
check
that?
it.
Yes,
Stop
check
it.
the digoxin level.
Yeah,
We don't
check it.
stop it, right? We need to check it. Okay, we're probably going to call our provider and be like, hey, this patient just went into junctional rhythm. Their digoxin level hasn't been drawn in, 2 days. Can we get a level? And they're going to be like, yep, absolutely, get it stat. And we're going to get that level and we're going to call it to our provider. Now, that provider's probably going to go, well, when's their next dose of digoxin due? If it's due soon, they probably will hold it. But remember, we can't stop a drug. That's not in our scope of practice. Okay? We can call a provider and say, hey, this is what I found. Do you want me to give this medication? All right. Symptoms. Now, I want you to look at these symptoms: weakness, fatigue, chest pain, anxiety, and dizziness. Those are all symptoms of poor perfusion. That's what they're demonstrating. They have a low heart rate. They are showing signs of poor perfusion. Okay? How do we do it? Or how do we treat it? Well, we find and treat the underlying cause. If it's digoxin toxicity, then that provider is gonna hold the digoxin and probably change the dose. And when we get that digoxin level, they're probably gonna make us get a potassium level too. Okay. If your rate becomes too low, so remember in sinus bradycardia, we used atropine. If we have junctional bradycardia, we're going to use atropine. If we have a bradycardia, we are going to use atropine. That is the drug we use for low rates. Bradycardia is atropine. That's the drug that you will give. Okay, so now I'm going to move on. We're not going to practice any of these, and we won't practice any of these either. So when we get to practices. Okay, the last atrial rhythm we're going to talk about is called supraventricular tachycardia. What does supra mean? S-U-P-R-A.
On top.
On
Above.
top, above. Yep. So it's above the ventricle. So the initial impulse is originating above the ventricles. And this is important because we're going to learn about ventricular tachycardia. This is supraventricular tachycardia. Okay? So it comes above. And how do we know that it comes above the ventricles? Because our QRS is normal or within normal limits. Like if you look at this, this again looks like it's about 1.5 to 2 squares. So 0.06 to 0.08. Okay? So that's how we know. So again, if you, like I said, you look at these QRSs right here, and they're very narrow. Now, the reason that we call it supraventricular tachycardia versus a sinus tachycardia or an AFib uncontrolled is because, do you see how there's all we have between the two QRSs is a T wave. That is not your P wave, by the way. This is not your P wave. Okay? It is your T wave. No. So, this here is your T wave. That is not your P wave. Because these complexes are so close together that if there is a P wave, it's buried under that T wave. So we can't see it. Because the rate's too quick, we can't tell if this is an atrial fibrillation or if it's a sinus tachycardia. So we call it, but either way, whether it's a sinus tachycardia or an AFib or a flutter that is uncontrolled, all of those originate above the ventricle. And that's why we call it supraventricular tachycardia. Okay? Your rate is going to be between 150 and 200 beats per minute. So when you get a heart rate above 150 and you have a narrow QRS, you have supraventricular tachycardia, or SVT. You will see that abbreviation a lot of places because we don't like to say whole words in medicine. We have an abbreviation for everything, okay? So SVT, supraventricular tachycardia. So if we count these, we're going to have, let's see, we have 1, 2, why is it being a brat? Okay, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So we're at 150, okay? But remember, we're doing the rough estimate. So this probably really is above 150. But if we count the QRSs and it's 15 or higher, that's SVT. So your rhythm is also very regular. See how it's very rhythmic? The distance between these looks about the same, every QRS. Your P wave is undetectable. We don't know if there's a P wave in there or not because it's buried under your T wave, okay? This put PR interval as normal, and that's wrong. Your PR interval is unmeasurable. If you can't detect your P wave, you can't measure your PR interval. I'm sorry, I'm telling you that this slide is wrong. Your PR interval should be unmeasurable, not normal, because you can't measure it. If you don't have a P wave, you can't measure a PR interval. Okay. And we said your QRS is normal or narrow. So this one's I told you it's probably 0.06 to 0.08. Either one is fine. It's normal. Okay. What are some causes? Emotional stress. And we're talking about high levels of stress, not little levels of stress. Okay. Nursing school. Haha. So high levels of stress. The other thing is, and this is probably the more common, and that is stimulants. Okay? Things like cocaine. People who are taking Ritalin or Concerta, things like that, that are not prescribed to them, not being regulated by a provider. Okay? Too much caffeine, those monster drinks, these teenagers who are drinking these monster drinks, right? One right after another, and then they end up in SVT. So that's not good. All right. Symptoms. Our symptoms are going to be similar to the other ones of poor perfusion. If your heart is beating that quick, how much fill time do you think that ventricle has? Okay. It doesn't have very much fill time. And if it doesn't have very much fill time, we're not getting a whole lot of blood in the heart to be pushed out. Remember, if we're only getting 30 mLs in the heart because the ventricles don't have time to relax, and I only push out 70% of that, I'm only moving like 25 mLs. Do you see what I'm saying? So because that heart can't relax, those ventricles don't have time to relax, we are not going to fill. Yeah, not a lot. So we're not moving a lot of blood, and therefore they end up with signs and symptoms of poor perfusion, on top of the fact that their heart's racing. And that's a little uncomfortable for sure. Okay. So how do we treat this? Remember, we always go from least invasive to most invasive. So the first thing we're going to do is the least invasive measure, which is called vagal maneuvers. Somebody tell me what a vagal maneuver is.
Is that when you bear down?
It is when you bear down. Yes. Okay. So you're going to bear down, have them tell them to like push like they're going to have a bowel movement. Okay. Or if it's a woman who's had a kid, push like you're in labor. So it's the same thing. You're going to, hold your breath and push down in your abdomen. That stimulates the vagus nerve. I can't do that too much because my blood pressure is low. My blood pressure runs on the lower side. Also, there is a thing called like having them blow through a straw. So like, let's say you have somebody in SVT who has some developmental delays. Having them blow through a small straw does the same thing. Think about if you're trying to blow up a balloon or blow through a small straw, you have to bear down. Okay. They use some old textbooks, and I'll be honest, I didn't look to see if yours did or not, or you may run across some old nurses who will tell you to do a carotid massage. So a carotid massage, yep, had them blow through a straw. Yep, it's a very common trick. A carotid massage is where you actually go in and massage the carotid. It does stimulate the vagus nerve, but we don't do that anymore because if somebody has plaque in their carotid and we go in and massage it, we could dislodge plaque and cause a stroke. So we don't do that anymore. Okay. So if you see that somewhere that is old school, we don't do that. There's also this thing called a diving reflex that stimulates the vagal nerve. And that is where you basically put, you get a basin of water and you like put their head in the water and it simulates diving and it will stimulate the vagus nerve. And I have done that before, tried to trigger the diving reflex. If those things don't work, and I'm not gonna lie, there's a lot of times those things don't work, okay? If those things don't work, we are now going to have to give IV adenosine. Remember, bradycardia is atropine. Tachycardia is adenosine, okay? Adenosine, we're going to start by giving 6 milligrams. The half-life on adenosine is minutes, meaning we literally have minutes before that drug is no longer active. So it usually is given with 2 people because one person is going to push the drug and the other person is going to push a flush hard and fast because we have to get that drug to the heart quick, because it wears off really quick. If 6 milligrams doesn't work, we're going to give 12. If 12 milligrams doesn't work, we give no more adenosine. They may opt to try and percutaneous pace, meaning capture the heart and then kind of pace it down. They may try cardioversion, but don't worry about that. What I do want you to know about IV adenosine, okay, before I say this, has anybody here had SVT or IV adenosine?
I have not, but I was in the ER during a clinical when they gave it to a patient.
Okay. So if it works, it stops the heart for a couple of seconds, a second, maybe 2, maybe 3. I never tell my patient that. What I will tell them is that they may feel a little weird and they may have a little, like a slight amount of chest pain. That may happen. But I never tell my patient that we're technically stopping their heart for a second or two, but that is what we're doing. We are trying to chemically stop the heart for a second and then get that sinus node to like go back to a regular rhythm. Okay. It's kind of like a reset. And it doesn't last long because remember I told you adenosine has a half-life of a couple minutes. It only works for a short amount of time and then poof, it's gone. Okay? That's why we have to push it very rapidly IV. This is one drug we are never going to slow push IV. We slam this in because we got to get to the heart quickly. Okay? Any questions about this? Give me just a second, guys. Actually, why don't you take like a quick, let's just take a quick 10-minute break and we'll come back at 10:20. I'm back. Give me just a minute. I have to do something really quick. Okay. All right. So you guys can still see my screen, correct? Can you guys still see my screen?
Yes.
Yes. Okay. Thank you so much. Okay. All right. So let's practice. Let's do a couple of practices really quick. Okay. And then we will get through these and move on to ventricular rates. Okay. So when I look at this, what is my rate? What's the rate, guys?
90.
90. Good job. Okay. Okay. So it is 90. Sorry, I'm trying to draw with my mouse, so it would help if I draw the right thing. Instead of that, let's do this again and actually, anyways. Okay. Is the rhythm regular or irregular?
Irregular.
It is irregular. Okay. Okay. Can we identify a P wave?
No.
Can you identify one P wave in front of every QRS? No. So, no, unidentifiable, right? So that's what we use here, unidentifiable. I can't write. Writing with the mouse is not easy, just let me tell you. Okay? Unidentifiable. Can we measure a PR interval?
No.
No, so it's unmeasurable. Because we don't have a P wave that we can measure. Okay. All right. What about our QRS complex? What is the QRS complex? So if I go from here, because it's going to start here, one box, two, I think we have about 2.5 boxes. So what's your measurement if you have 2.5 boxes? Not quite, Tony. Good guess, though.
0.1.
0.10. Each
Yeah.
box is for 0.04. So 0.04 plus 0.04 is 0.08. Half of that is going to be 0.02. You add that to our 0.08 and we get 0.10. Is that normal? Is that within normal range? Yes, no, maybe so. Zero point 10. Is that within normal
Yes.
range?
Yeah.
Yes, it is. Okay. So we know that that's going to be the 0.10. So what is your interpretation? What rhythm do you think you have here? It's irregular. We can't identify our P waves. We can't measure a PR interval. Our QRS is normal.
Would it be sinus tachycardia?
Nope, with sinus, we're going to have a regular rhythm.
It's
And
AFib.
Maria, you are correct. With sinus tach, you would have a regular rhythm, and this is irregular. Right? So it is atrial
Fibrillation.
fibrillation. Yep. Because remember, if it was a flutter, all those P waves would look the same. It looks like saw teeth. Okay. This is a hot mess on my bottom line. This is just a bunch of squiggles. That's AFib. Those atria are fibrillating. Okay. So now let's go. All right, let's look at this one. What is the rate? Oh, sorry. In our AFib, our rate was 90. Is that controlled or uncontrolled?
It's controlled.
It is controlled. Thank you. Sorry, I forgot that part. Okay, so now let's look at this. What's our rate?
70.
70. Good job. Okay. I can't write. I can't write with a stupid mouse. I am not that talented. That's just me. Okay, 70. What is the rhythm, regular or irregular?
Regular.
It is regular. Yep. Looks pretty regular to me. Can we identify P waves?
No.
No. We
No.
can't really identify a P wave, right?
Yes.
So, but we have sawtooth flutter waves. So we can just put that. We can put that there are flutter waves because that's how you describe these P waves. Okay, flutter waves. Can we measure a PR interval?
No.
No, because we can't really identify one P wave. So it's unmeasurable. I'm not writing that out again. You know how to write unmeasurable. What is my QRS complex?
It's normal.
It is narrow.
Is it 0.8?
Anybody got a guess here? Can you? Yeah, I would say probably 0.08. Don't forget that other 0.08. So is that normal?
It's normal.
It is normal. That's correct. Okay. All right. So what do you think we have here? What rhythm?
A flutter.
A flutter. Very good. Is this controlled or uncontrolled?
Controlled.
Controlled.
Controlled. Okay. So, and don't forget to know what causes these rhythms, okay, and how we treat them. That's why I tell you make those flashcards because that will help you with all that. There we go. All right. All right, let's look at this one. What's our rate?
$120.
How much?
200.
200.
Oh, 200?
Yeah, we have 20, right? 20 complexes.
Oh, 200, yes.
Okay. So it is 200. I'm not going to write. I'm tired of trying to write with this silly mouse. So 200 is our rate. Is our rhythm regular?
Yes.
Yes. Can we identify a P wave?
No,
No, we can't. So can we measure a PR interval?
no,
So it's unmeasurable. Our P wave is unidentifiable. Our interval is unmeasurable. What's our QRS complex?
Miss
small brain.
Brandy,
Yes.
I'm sorry, everyone's dumb. Why is the big shark tooth in front of the complex not the P wave right now?
That is our T wave.
Okay, because it swallows up the P wave, right?
Yes, that is
Okay,
correct.
thank you.
Yep. So that P wave may be happening underneath, but the T wave gives more of an electrical offset that's going to bury that P wave underneath. It's not a
Thank
stupid
you very much.
question. Yep. T eats the P. Yes, it does. Okay. So it's buried under there, and we can't, because it's moving so quick, there's no space in between them. All we're going to be able to see is that T wave. Okay. So our QRS interval, anybody got?
Does it look like maybe 1.5?
That's what I would give it, is 1.5.
Like a 0.06?
Correct. Yep. Is that normal? Is 0.06 normal?
Yes.
Yes. Okay. So what do you think we have here? What rhythm is this? What's our interpretation?
Ventricular tachycardia.
SVT.
SVT. Good job. Good job, Amber. This is SVT. Supraventricular tachycardia. Okay. Supraventricular tachycardia. So what will happen, what happens in real life is that we try and slow this down. They're going to get a 12 lead EKG to see if in a different lead they can pick something up between the complexes, but at 200, I doubt it. They're going to try and slow this rate down and then try and see what's going on underneath. Is this a sinus tachycardia, or is this an atrial fibrillation? But we don't know until we get this rate slowed down what the underlying problem is. Okay. And what did we say was a major cause for SVT?
Stress.
High levels of stress.
Energy
Stress,
drinks.
high level stress, and what else?
Stimulants.
Stimulants. Yep. High levels of stress, anxiety, and stimulants. All right. Good job, guys. All right. Let's look at our next one. What's our rate?
Two hundred.
200.
200. All right. Is our rhythm regular or irregular?
Regular?
It is
Regular.
regular. Yep. What's, can we identify a P wave?
No.
Yes.
No, I can't tell you in a P and a T.
Because that little blip right here is, hold on, let me get this little blip that you guys are seeing. That's just a return to your isometric line. It's just a funky, this is your T wave. Okay. That is not a P wave. That is a T wave right here. Those are T waves. Okay. Because you see how this dips down? If it was a T wave, it would go up. This is going down. If it was a T wave, it would go up and then you'd have a second upward inflection for your P. That's how I know it's not that's how I know this isn't a P wave. It's a T wave because this is not a T wave. It goes down. The inflection goes down. It could just be lead placement. So I have no P wave. Can I measure a PR interval? No.
No.
Good job. What does my QRS look like?
0.6.
Yep, it does look like 0.06, correct. So and that's normal, we established that. So what do we have here?
SVT.
SVT. Good job. Okay. All right, let's look at this. What's my rate?
$70.
70, good job. Yep. Okay. Is it regular or irregular?
Irregular.
Irregular.
It's irregular. Yep, it's irregular. Do we have P waves we can identify?
Maybe
No.
no.
No, correct. There's not, oh shoot. There's not one specific P wave in front of each T wave. Okay. Can we measure a PR interval if we don't have if our P wave is unidentifiable? Then what is our PR interval?
Not
What's the word?
measurable.
Unmeasurable. Correct. Yep. Unmeasurable. What's our QRS complex?
They look like they vary. Like they're not all uniform. So
Yes, they are not all uniform.
Yeah, it does come up off the line in different places. Again, that could be patient movement or lead placement. But when I look at it, I go from here to about here. I get about 1.5. And if you look at this, you're still going to get about 1.5.
Then 0.06 then.
Yeah. So I would go with 0.06. So they look different, but when you actually look at them and measure them, because this is where you're gonna, oops, I took my, this right here is because this is your QRS. So this is your S. This is gonna be your S here at the end of this QRS. So you can, they all probably measure out to be pretty close to each other. So, yeah. So what do we have here? What
Atrial fibrillation.
It's an AFib. Yeah.
it is arterial fibrillation or AFib.
Controlled.
It is controlled. Good. Yes, ma'am. All right. All right, one more practice for this. Oh, okay. What's our rate?
100.
So I
One
have
ten.
110 is what I got. Yeah, 1, 2,
10.
3, 4, 5, 6, 7, 8, 9, 10, 11. Yeah, 110 is what I got.
I thought you wouldn't count that first one because you can't see the whole thing.
I would still count it because
Okay,
you.
because Miss Ange told us at clinicals if the whole thing wasn't on there, not to count it.
Oh,
Yeah.
did she? Okay, I mean, I'm not gonna, here's the thing, I'm not gonna test for the controlled or uncontrolled. So you're gonna have choices when it comes to your rhythms. So I won't make it that, I'm not trying to trick anybody. I'm not gonna put like 100 and 110. I'll put like 110 and 80 as an option. You see what I'm saying? I'm not trying to trick anybody. So if you want to say 100 or 110, I'm good with either, actually. Because the truth is, in real life, we would measure this. We would measure these boxes. Remember I showed you that little card I used to carry that talked about how many boxes were in between? So whether you put 100 or 110, I'm cool. Is the rhythm regular or irregular?
Regular.
Regular.
Regular. Okay. Can you identify a P wave?
No.
They're unidentifiable flutter waves.
Yes,
So,
yeah,
so
yeah,
to,
that is correct. They are flutter waves. This time, because your flutter waves are different, your T gets buried under your flutter wave. When the 2 or 3 that are here look the same, those are not a T wave and a P wave. They're P waves. They're flutter waves. And we can see how that looks, right? Like a flutter, like a sawtooth. So I'm just explaining why one of these isn't a T wave, because that T wave is buried under these flutter waves. So it is unidentifiable, and it is flutter waves. Can we measure a PR interval?
narrow.
No, it is unmeasurable. What is your QRS? Remember, this is a rough guess, guys.
I counted like 3 boxes.
Yeah, I think it's probably right. That's why I'm looking at it. I think,
2.5.
Like a 0.12, which is at the high end of normal.
yep, but still normal. Correct. Good job.
So in
All right.
exam, if somebody calculate that at 2.5 instead of 3, is that correct still or no?
2 point. What? Oh, yeah, I'm fine with that.
Yeah, because they are too small. So
Yeah, it's fine. Right. That's what I'm saying, guys. I'm not looking to I'm not looking to trick you. Okay. So whether you had 2.5, which would be 0.1, or 2 or 3, which is 0.12, either way, it's still normal, right? Both of
yes,
those are normal. So I'm not going to get caught up over little stuff like that. What's your interpretation?
A
What?
flutter?
a
A
flutter.
flutter. Good job. Good job. All right. We got through our atrial rhythms. So your rhythms that you have to know: normal sinus rhythm, sinus bradycardia, sinus tachycardia, atrial fibrillation, atrial flutter, and supraventricular tachycardia. All right, that's where we're at so far. You got 6 rhythms. And now we're going to talk about our ventricular rhythms. Okay. So ventricular rhythms are never a good thing. There is not a good ventricular rhythm ever, because that means that the ventricles are pacing the heart and taking over. That's never a good thing, ever. Okay? So the first ventricular rhythm problem that we're going to talk about is ventricular fibrillation. Remember, we talked about atrial fibrillation. They're fibrillating or quivering, contracting too quick. Well, now the ventricles are doing that. Is that conducive to life? If
No.
your ventricles are doing nothing but quivering and not contracting, are you alive?
No.
You are not. That is correct. Okay? If you see this on the monitor and you run into your patient's room and they're sitting there eating their lunch, watching TV, I promise you they are not in ventricular fibrillation. You got to lead loose or something, okay? But if it is true ventricular fibrillation, your patient has no pulse. They are not breathing. So you don't have a rate. You can't get a rate out of this. Show me, like, where in here is a QRS complex? Show me. There isn't one, right? Okay. So this is rapid and disorganized. The rhythm, they consider it irregular, although really you don't have a rhythm. Personally, I would say the rhythm is non-existent. Okay. There are no visible P waves. You can't measure a PR interval, nor can you measure a QRS. Okay. This is a medical emergency. Oops. Your patient is dead. Okay. So what are some things that can cause ventricular fibrillation, or VFib? So we call and atrial fibrillation AFib, ventricular fibrillation they call VFib. Okay. So myocardial infarction, especially if it's a large area of damage to the heart, like your LAD. If you have a massive blockage in your LAD, that there's no blood supply going to the ventricles. Sorry guys, I'm getting a little chilled. And your heart's gonna stop. Electrolyte imbalances. In particular, and you don't have to know this rhythm, but there is a rhythm called torsades des points, which means twisting of the points. And so it's a VFib, but you will see how it kind of twists on itself. And that is related specifically to magnesium. Low magnesium causes torsades des points. If you see a patient in torsades, you know they have low magnesium. The other electrolyte, tell me, what is the other electrolyte imbalance that could potentially cause ventricular fibrillation?
Potassium.
Potassium.
Potassium, you got it. Yep. Okay. Drug toxicity or overdose. Electrical shock. This is what, remember I said, if in that T, that refractory phase, when the T wave or when the ventricles are trying to repolarize, okay? If somebody gets hit or you get shocked, then it will throw your heart into ventricular fibrillation. That's why when we do cardioversion, we have to sync our defibrillator. This patient, we don't have anything to sync to, okay? Hypothermia can cause ventricular fibrillation, and then untreated ventricular tachycardia, or VTAC, which is our next rhythm we're going to talk about. VTAC will eventually progress into VFib, okay? What are your symptoms? Loss of consciousness, no pulse, probably can't get a blood pressure. If they're breathing, it's going to be agonal. What does that mean? What does agonal breathing mean?
Like they're struggling to breathe.
Painful?
Full.
So
Breath.
agonal breathing is going to be, they may take 2 breaths, 3 breaths a minute. And they do, it's like that gaping, like that, and they go. So that's an agonal breathing. It's very, very low and completely ineffective. So, in other words, your patient's dead or dying, however you want to put it. So, the only way to treat this problem is with CPR and defibrillation. This is not going to be synced. We have nothing to sync to. It's going to be when they call for the shock, you're going to shock. It's going to shock right away. Remember, if you are shocking, or even with the defibrillators in the hospital, they attach pads. There's pads on, okay? If they tell you clear that bed, you better make sure you're not touching it in any way. You will get popped, okay? And usually, if you see a code, when somebody says clear, you will see everybody go clear and back up. Put their hands up, because you don't want to be touching that bed when that shock goes through. And then you're going to follow ACLS protocol. And I can tell you for VFib, I've done this too many years, it is going to be shock and epi. That's what you're going to be doing, epinephrine. So defibrillation and epinephrine. Okay. Any questions about ventricular fibrillation, or VFib? Okay. Our next rhythm is ventricular tachycardia. Okay. So this is abnormal electrical impulse causing the ventricles contract at a very fast rate. And the electrical impulse is coming from the ventricles, not the atria. Because when it's coming from the atria, we have that pretty narrow QRS, right? If you look at this, because you're not going to see a P wave or a T wave in here. And so this is your QRS, this whole thing, okay? And if you look at that, that's probably 5 squares. Easy. Okay. Now I didn't learn this way, but somebody else taught me this, that it looks like ghosts holding hands. If you draw little eyes in there, and then it looks like ghosts holding hands. I can't draw it because my thing's too fat, but this is ventricular tachycardia. Your heart rate is going to be between 100 and 250 beats per minute. You can't visualize your P wave or identify it, okay? There probably isn't one, because it's coming from the impulse is coming from the ventricles. Therefore,
So at this time, there is no atrium. What are they doing? Are they like a repolarization, or doing their repolarization, or they are not existing at this time, or they're dead?
we'll talk about that. We will talk
Okay.
about that. I'm going to
Okay.
get to that, I promise. Yep.
Okay.
So Your P wave is unidentifiable and your PR interval is unmeasurable. Your QRS is wide and you can measure it and put that measurement in there. So if you have a patient who is in ventricular tachycardia or VFib, they may be unconscious or they may be completely awake and alert and oriented. Okay, so it depends on which you have, what you do. So what can cause these rhythms? Well, myocardial infarction. The heart understand that myocardial infarction can cause a lot of dysrhythmias or arrhythmias. The heart took a hit, right? Part of that heart did not get oxygen that it needs, and there's dead tissue. So a lot of these serious arrhythmias can be caused by a myocardial infarction. It can be caused by coronary artery disease, heart failure, electrolyte imbalance, potassium in particular, or magnesium, digoxin toxicity, or stimulants. All right, so what are our symptoms? Well, if they're awake, they may be unsymptomatic at first and have no symptoms. But if we don't fix that, they will become symptomatic. Okay? It will happen. They may be awake but have palpitations, shortness of breath, and chest pain. Or they may be unconscious. If you have, and when they're unconscious, they're pulseless, okay? If you have pulseless ventricular tachycardia, you are going to do CPR and defibrillation and follow ACLS protocol. And I know you guys got, like, didn't she give you like a sheet that has the ACLS protocol on it somewhere? I don't remember. I thought we did, but I thought there was one in there, but I could be wrong. But ACLS protocol, I mean, you guys don't have to, you're not ACLS certified, but ventricular tachycardia is going to be CPR and then we're going to shock, not cardiovert, shock. They don't have a pulse, we shock. Okay? And then follow the ACLS protocol, which is typically going to start with epi. So we're going to use epinephrine. And the other drug that we use during ACLS protocol is amiodarone. Okay? If they have a pulse and they're stable, we're going to do IV amiodarone. That's our antiarrhythmic drug. Okay? And we are going to try synchronized cardioversion. So because they have a pulse, we're going to sync. Because we want that shock delivered at the T. No, not at the T, at the R, not the T. We do not want it delivered at the T. We want it delivered at the R. Did somebody just miss it? Okay, I don't know. I'll have to look at that. Okay. So heart rate, oh, we went through all this, unmeasurable weight. Okay, so those are our treatments. If they have a pulse, synchronized cardioversion, IV amiodarone, which is our antiarrhythmic arrhythmic drug. If they are pulseless, CPR, we get on the chest, basic life support. No pulse, start CPR. Then we're going to defibrillate because this is a shockable rhythm. And then follow ACLS protocol, which is typically going to use epinephrine and amiodarone. Any questions about this? All right, so we just added 2 more rhythms you have to know. Ventricular fibrillation and ventricular tachycardia. Okay. All right, let's practice. What's our rate? How many beats a minute?
It's either 150 or 160.
Yeah, I agree, 150, 160. Is it regular or irregular?
Regular.
It is regular. Can we identify a P wave?
No,
No.
Not
Can we
identifiable.
measure a PR interval?
No.
no.
Our QRS,
It's not existing.
yeah, it's wide. You'll hear like some people when they interpret this, they'll call the QRS wide and bizarre.
Okay.
An old term. Yep. Okay. So very wide. So what rhythm do we have?
Ventricular
Beta.
tachycardia.
Yep. Ventricular tachycardia. Good job. So what's the first thing I need to know about this patient? I've identified my patient is in ventricular tachycardia. What's the first thing I need? Huh?
Is it consciousness? Is it conscious or
Okay, so are they conscious or do they have a pulse?
do they have
Right? I
pulse?
need to know if they have a pulse. Because if they don't have a pulse, CPR, fibrillation, ACLS protocol. If they have a pulse, I'm doing IV amiodarone and potentially
Okay.
synchronized cardioversion.
Okay.
So just understand that when we're identifying VTAC, we have to know if our patient has a pulse or doesn't have a pulse because treatment is different. All right, let's look at this. Can you identify a rate? What's your rate?
Unidentifiable.
It is completely unidentifiable. That is correct. We can't identify a rate. Is there a
No.
rhythm? I would put no or I would put irregular. Either would be acceptable. I would be fine with either, honestly. Because they're both correct in their own way. Do I have P waves?
No.
No. Cannot identify P waves. Can I measure a PR interval?
No.
Can I measure a QRS complex?
No, not existing.
No. And they're completely bizarre from each other. They're white, all that stuff. So what is my interpretation?
FF.
It is, yeah, VFib, ventricular fibrillation. Okay. If my patient is in VFib, do they have a pulse?
No.
No. So what am I
CPR.
doing?
CPR.
CPR and what?
Defibrillate.
Defibrillate and then follow ACLS protocol. Okay. Next one. Do we have a rate? Can
No.
you get a rate out of that? No. Okay. What about rhythm?
Irregular.
Irregular.
Irregular, or you can put undeterminable. Either is acceptable. Can I identify a P wave?
No.
No. Can I measure a PR interval?
No.
Can I measure a QRS complex?
No.
No. Okay. What rhythm do I have?
VFib.
It is ventricular fibrillation, correct. Does my patient have a pulse?
No.
No. So I'm going to do CPR, defibrillation, and follow ACLS protocol. All right. Do we have a rate? What's your rate?
160.
150, 160.
Yeah, 150, 160. Okay. Is it regular or irregular?
Regular.
Regular. Can you identify a P wave?
No.
Nope. Unidentifiable. Can you measure a PR interval?
Nope.
No.
Okay. Can you measure a QRS complex?
No.
I mean,
Okay.
yeah.
You
Is
could.
it that
It's gonna be really wide, bizarre.
really wide? Yeah.
Yeah. Okay. You could potentially. You are correct. What do we have here?
VTAC.
VTAC. Good job. And what's the first thing I need to know about my patient who's in VTAC?
Pause.
A pulse.
Pulse. Yep. Do they have a pulse or not? If they don't have a pulse, CPR, defibrillation, follow ACLS protocol. If they have a pulse, IV amiodarone and synchronized cardioversion. Okay. All right. So you need to know sinus, normal sinus rhythms, sinus bradycardia, sinus tachycardia, atrial fib, atrial flutter, supraventricular tachycardia, ventricular fibrillation, and ventricular tachycardia. So we've got 8 rhythms right now you need to know. Okay. And we're going to start, now we're going to talk about heart blocks. Okay. So when we have heart blocks, there are 3 types of heart blocks. Okay. A first degree heart block is all we have is a PR interval that is longer than normal. So typically our rate is normal. I mean, it may be a little, sometimes you can be in a bradycardia with this, but typically it's normal. Okay. Your rhythm is regular. You have a P wave that is upright and before every QRS, just like in sinus rhythm, normal sinus rhythm. The difference is my PR interval right here is prolonged. It's going to be greater than 0.2 seconds. So when I measure that, it's going to be 0.22, 0.24, 0.2. It's going to be bigger than 0.2. Okay? But it should be, so if it, let's say that it's 0.24. Well, it'll be 0.24 here also, and 0.24 here also. But, or within that, okay? Very close to that. And so I am going to measure every single PR interval because I have to know that they're all about the same, because that's what makes it a first degree. If my PR interval stays consistent, mind you, it's prolonged but consistent, I have first degree heart block. My QRS is going to be narrow and normal. Okay. But every PR interval will be about the same. And you'll understand what I mean when I say about the same when we start talking about second degrees. Okay. So that's the only difference between first degree heart block and normal sinus rhythm. This can be normal for some patients. Okay. Other causes are things like aging. As we get older, our heart doesn't, everything stops working like it used to, okay? It all starts falling apart. So, coronary artery disease, electrolyte imbalances, and medications that may slow AV conduction, in particular, beta blockers and calcium channel blockers, because they both slow the heart rate. Both of those affect heart rate. Okay, so calcium channel blockers and beta blockers can prolong your AV conduction and cause a first degree heart block. Do you think they're going to stop that medication for the patient?
No.
They may not. They may not, but they put them on it for a reason. So if the underlying rhythm that they're trying to, dysrhythmia that they're trying to treat with the beta blocker is worse, and all we have is a first degree heart block, but they're perfusing and their heart rate is good, then we're not going to mess with it. We're going to watch it, but we're not going to change it, more than likely. These patients are usually completely asymptomatic. This is just found by chance. This usually requires no treatment, but it's going to be monitored because they want to make sure that this first degree heart block doesn't progress into a second or third degree heart block. All right. Now we're going to talk about second degree heart blocks. When we talk about second degree heart blocks, I want you to know that there's two second degree heart blocks. The first is a second degree type 1, and then we have a second degree type 2, and we're going to talk about those, okay? A second degree type 1 is also called a Wenckebach. And this is right here. You don't have to, it's right here on your slide. That's how you pronounce that. Okay? Wenckebach, right here. That's what you have. Okay? So what is Wenckebach or second degree type 1? It is when your PR interval progressively gets longer and longer until a QRS is dropped. Okay, so what you're going to see is your first interval might actually be normal. Oh, here. Oops. Your first degree might be, your very first PR interval might be within normal range. But then the second one is longer than the first one. And then the third one is longer than the second one. And then you have this P wave here, but no QRS. It dropped. And then we go back to a normal PR interval, and then it lengthens, and then this is probably a drop. Unfortunately, we can't see it, but I would bet that you have a drop right there, past that one. Okay? So, longer drop. Now you have Winky-Bach. That saying has been around since I was in nursing school, and I'm not going to tell you how long ago that was. Okay? Longer drop. Now you have Winky-Bach. So that's second degree type 1. So your rate's normal, your rhythm is regular except for that dropped beat. Your P wave is normal, but your PR interval gradually prolongs, so it gets longer and longer. Your QRS drops every fourth beat. Longer drop. Okay. So, what can cause this? One is rheumatic fever. Okay, a history of rheumatic fever or current rheumatic fever. Surprise, surprise, myocardial infarction. Medications like your beta blockers and your calcium channel blockers. Just like in type 1. And increased vagal tone. So that vagus nerve is a little more toned or increased than normal. And that can cause this. Sorry guys, it's getting cold in here. I have to go outside just to warm up. It's crazy. Okay. These patients may be asymptomatic or they can be symptomatic. Symptomatic's typically going to be signs of poor perfusion. Dizziness, shortness of breath, weakness. AMS stands for altered mental status and chest pain. If they are symptomatic, you want to get vital signs, get them on some oxygen, get a 12-lead, well, you have to notify your MD right away. You're going to get a 12-lead EKG and you're going to draw labs. Any questions about this? Okay. So remember, first degree heart block, your PR interval is longer than normal, but it stays consistent. Second degree type 1, also known as Winky-Bach, your PR interval gets longer. You drop a QRS, then it gets longer, drop a QRS. Okay, so longer, drop. Now you have Winky-Bach. All right. Second degree type 2 is called Mobitz 2. Okay. So your P waves stay constant. They don't progressively lengthen. But your QRS just randomly gets dropped. So every once in a while, that AV node just doesn't let something go through. So it's not a pattern of longer drop. That's Winky-Bach. This is, if some P's don't get through, then you have Mobitz 2. There's not a pattern to it, okay? Your PR interval is constant except for your dropped QRS. Your rate's normal. Your rhythm is regular except for that drop beat. Your P waves are normal. And what they mean by marching along is that if you measured from this P wave to this P wave, like we do the QRS, it would be the same distance as this P wave to this P wave. And then it would be the same distance from this, from this P wave to this P wave, okay? And then this P wave to this one, and then that one to that one. So the distance between all of your P waves is consistent. They march along. You just randomly drop a beat. Okay? So your QRS is normal except for that random drop. So what can cause this? Surprise, surprise, myocardial infarction and coronary artery disease. Everybody's shocked by this, right? Wouldn't have guessed that. Then we have cardiomyopathy, which is just disease of the heart muscle, okay? And medications, beta blockers and calcium channel blockers. Again, your symptoms, if they have them, are going to be symptoms of poor perfusion, dizziness, weakness, syncope. Your treatment, if they're asymptomatic, they consult cardiology and look at the meds. If they're symptomatic, you're going to notify that provider because they may end up getting some temporary pacing and they may end up getting a permanent pacemaker. And typically they're symptomatic if because of these dropped beats, it drops their heart rate low. That's when they get symptomatic. Because if your heart rate's already 60 and you're dropping every third beat, well, now you're down to like 50 something. Okay. And so it's poor perfusion. That's what your symptoms are. Any questions about second degree heart block type 2 or Mobitz 2? If some P's don't get through, then you have a Mobitz 2. Longer drop, then you have Winky-Bach, which is type 1. Okay. Third degree heart block is where your P waves fire and your QRS goes through, but they have no relation to each other. So if you measure, like you see here, if you measure your from P wave to P wave, you can even do this one, right? We can go P wave. Oh, helps if I take it. P wave to P wave, P wave to P wave, and these are consistent. There would be a P wave in there. P wave, P wave, P. See how they march through? Oops. Okay. So they're consistent. And then your QRS is also consistent, but not with each other. You go QRS to QRS, QRS to QRS. They don't talk to each other at all. It's a complete loss of communication between the atria and the ventricles. The atria is firing at its pace, And the ventricles, this looks like they're getting their, it's the AV node that's giving them their signal. But it's two totally different things. They do not communicate with each other. Okay? Everybody see this? Okay. If your P's and Q's don't agree, then you have a third degree. Okay? Third degree heart block is usually I've personally never seen a patient in third degree heart block not end up getting paced with a pacemaker. And the reason is because usually their heart rate is below 60. And sometimes, like the heart rate, if we look at this, right, the heart rate is 30. You going to perfuse well at 30, a heart rate of 30? You think you're going to perfuse well with a heart rate of 30?
No.
No, you are not. Okay. So they're going to be symptomatic. And their symptoms are going to be signs of poor perfusion, pale, clammy, weak pulses, chest pain, hypotension. They don't have cardiac output. Okay. So what can cause this? Myocardial infarction, coronary artery disease, cardiomyopathy, digoxin. So now our medicine is different. All the other ones we talked about beta blockers and calcium channel blockers, right? Type 1 and both type 2s. But with third degree heart block, dig toxicity is the most likely culprit if it's a medication. Okay. Now, your second degree heart block, type 2, your MOBITS, is the one that is most likely to progress into your type 3 heart block, but any heart block can progress to a third degree heart block. Right? We're going to treat with atropine because it's a bradycardia, correct? Remember I said, if we have a bradycardia, we treat with atropine. And they're probably going to get this patient on a temporary pacer, so transcutaneous pacing. It's like through the chest wall until they can get him to OR and put in a permanent pacemaker. So we have type 1. Your PR interval is prolonged, but it's the same for every beat. Then we have our type 2s. Type 2, or we have our second degree heart block. Second degree heart block type 1 is our Winky box. So it gets longer, longer, longer drop. Now you have Winky box. Our second degree type 2, called MOBITS 2, is random. If some P's don't get through, then you have a MOBITS 2. So your PR interval stays the same like in type 1. It's longer, but it stays consistent. But now we just occasionally, it drops a QRS. We have that P wave there, but no QRS to go with it. And then our third degree heart block is when our P's and our QRSs don't talk. Our P's and our Q's don't agree. Then we have a third degree. All right. Any questions about heart blocks? So this is the one time, like we talked about, that I'm going to measure every one of my PR intervals. Let's see what I got going. Okay. And then the last rhythm you have to know is called asystole or flatline. This is no electrical activity in the heart. Zero, zilch, nada, nothing. There is no electrical activity in the heart. Okay? So we don't have a rate, we don't have a rhythm, we don't have a P wave, we don't have a PR interval, and we don't have a QRS because we have no electrical activity. What can cause this? Myocardial infarction, electrolyte imbalances, drug toxicities and overdose, electrical shock, hypothermia, and untreated VTAC. Your patient is dead, and they are officially dead this time. Okay? They are dead. That heart has stopped. They will not be more than likely breathing. You will not have a pulse. They will not be awake. They will be unconscious. So, how are we going to treat this? Well, we can't shock it. You have to have electricity to shock electricity. Okay? We have to have electricity to use electricity. And because asystole has no electrical activity in the heart, we don't shock. We do CPR and epinephrine. CPR and epinephrine. CPR and epinephrine. We're going to follow our ACLS protocol. Okay. Now, what I'm going to tell you is if you ever see a code in true life and somebody's in asystole and they've been working that code for a while, you will have providers that will try and shock this. And they'll say, well, maybe it's a fine VFib and we just don't see it. Here's the truth. I have seen providers shock asystole. Not in the first 5 minutes, not in the first 10 minutes. Maybe when we're at 15 or 20 minutes, they might be like, let's shock because, and everybody will do it. And you want to know why? Because the patient's already dead. We can't make them any more dead. Okay. So we're going to throw everything we have. And that's typically what happens. The provider is like, I mean, like we've done epi, we've done amiodarone, we've done our drugs, we've done everything. Nothing's working. Let's try a shock. We got nothing left to lose at this point. But ACLS protocol, you do not shock that rhythm. Okay? Because you have to have electricity to treat with electricity. And asystole has no electrical activity. And here is what I was telling you about cardioversion versus defibrillation. Remember, I talked about defibrillation. Oops, I can't. Defibrillation is when it's emergent, they don't have a pulse, or they have a very, very, very weak pulse, okay? That's when I'm going to shock. No, actually, if they have a weak pulse, you still have to do cardioversion. This is no pulse. No pulse. Cardioversion, so we have a pulse, but we need to shock it because the rhythm isn't good. Look at the difference in the joules. So joules is your electrical ampage, okay? 50 to 200 is what's used in cardioversion. Defibrillation is 200 to 360, so you can see it's much more. Any questions about asystole? Okay. We're going to take a break. I'm going to give you time to maybe grab something to eat if you want, go to the bathroom. So it's 11:35. Let's come back at 11:55. Okay? Go stretch your legs, do what you need to. And then we'll do these practice strips and see where we are. All right. See you in 20. Sorry, guys, had to take a phone call real quick. All right. Let me share my screen again. Everybody able to see my screen? A thumbs up.
Yes.
Okay, beautiful. Thank you. Okay. So this is our first practice strip. What is the rate? Do we have a rate? I don't beat anybody for the wrong answer. Come on.
I don't know, would it be 10?
I say no.
So, yeah. So they have this down as asystole. That could have been like a blip in like somebody bumping the bed, something like that. But you could count that as a heart rate of 10, which is still, do you think your patient's awake, alert, pulse with
No.
10, heart rate of 10? No. Okay.
Unconscious.
Yeah. But they are calling this asystole. I don't know. It's not a great strip personally, I don't think. But so asystole, remember, sorry, we don't shock. Okay, no shocks. CPR and epinephrine. That's follow ACLS. Okay, this one. All right, do we have a rate here?
This is definitely a systole.
This is definitely asystole. That is correct. So we have no rate, no rhythm, no P-wave, nothing. Okay. So this is asystole, and patient's not gonna have a pulse. We're doing CPR and epinephrine, follow ACLS protocol. All right, what do we got going on here?
Pulse is 60.
Okay,
I mean, rates.
rate is 60. Okay. Are we regular or irregular?
It's regular.
Regular.
Regular. Okay. You guys, can you identify a P wave?
Yes.
Yes. Is there a P wave in front of every QRS?
Yes.
Okay. No random P waves hanging out anywhere. Okay. So what is our PR interval? Probably start about right here. And you're going to end about right here. Okay. So we have 1, 2, 3, 4, 5, 6 blocks. So what time, how much time is that?
.24.
Okay, 0.24. Or if you got 4.5 and you got 0.22, whatever, remember, it's not exact. We don't have calipers. Is that normal? 0.24, is that normal?
No.
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 It's what? Prolonged, right?
Prolonged, yeah.
So we have a prolonged Q. So now we know we have one. So now we're going to go and measure each of these P waves to make sure that it's about the same. Remember, these are rough measurements, so we want it about the same, okay? And we are getting, I mean, I'm looking at them, it's about 5.5 to 6 per P wave, right? Everybody see that?
Yes.
Okay. So we know that we're not dropping any QRSs. They're all the same. Okay. What's our QRS? And ended
I
about,
got a 0.10.
yeah, that sounds about right to me. Is that normal?
Yes.
Yes. Okay. So what do we have here? What is our interpretation?
Is it first degree?
It is a first degree heart block. Yes.
Yeah.
Okay. This is our first degree heart block. Okay. Next slide. Okay. What's our rate?
60.
60. Okay. Is our rhythm regular or irregular?
Regular.
Regular. Do we have a P wave in front of every QRS?
It's like prolonged. No.
Yeah, but we have one, right?
Hmm.
There is a P wave in front of every QRS. You can even see that one. Okay. What's our PR interval?
Be like a 0.28.
It's pretty long, so I haven't measured it, but I would go with that for sure. I got like 7.5 blocks. They got, whoever did this got 0.32. So either way, it's prolonged. 0.28, 0.32. So you definitely have a pretty prolonged, actually, I probably marked that one wrong because I marked it, really it should be marked here. So, but it's a prolonged PR, and you can see it's about the same here, right? They all, yeah, probably 8. Oops. Yep. So if you go and measure them, they all measure roughly about the same. Did we drop any QRSs?
No.
Okay. What is our QRS complex measure?
Like 2.5.
Yeah, 0.06 would kind of be my guess. Maybe, yeah, 0.06. So what's our interpretation?
Is it a first degree heart block?
Is it first degree? Zero? Yeah.
First degree heart block. Good job. All right. Now we're going to do this one. Okay. What is the rate?
60.
60.
60.
60. Okay. Is the rhythm regular?
Irregular.
It's regular except for the drop.
It is actually, yep,
Just
it's
the
regular
drop.
except for the drop. So
Okay.
I would actually say that that's regular because
Okay.
we know we dropped a beat. And if you put that beat roughly in here, you would find that it's going to march out. That's why they call it regular. Because even though we dropped that one beat, if you put that one beat in there where it's supposed to be, it will match up. Does that make sense? You guys understand why I say it's regular? Yes, no, maybe so.
Yes.
What
Okay.
if there was 2 beats dropped from that? Would it still be regular?
Well, we would have to look at it. We would have to go and look, okay? But in reality, it's pretty regular. Oops, I didn't mean to do that. God bless it. Stop it. Okay. I didn't mean to do that. I was trying to draw on the helps if I hit annotate. So, I mean, there might be a difference here. I guess I think you could argue both. So if it's mostly regular, should we select regular? Honestly, I could argue both. So if somebody put irregular, I don't know that I would mark them wrong. I'd probably look at it and then I'd look here and I would say, well, there's a bit of a gap here. So the truth is, it's not going to make that big of a difference to our interpretation. So I'm not going to spend a lot of time on this because it really isn't going to. And again, I think you could argue both ways. Do we have a P wave in front of every QRS?
Yes.
Yeah.
We do, except for the one dropped beat. And we know that was dropped. Okay, so now let's look at our PR interval. So if I look at this PR interval, I have roughly 1, 2, 3, 4 blocks, which would be 0.16. Is that a normal PR interval?
No.
PR interval is 0.16. Normal PR intervals below 0.2. So it would be normal.
Oh, okay.
Yeah. So your PR interval can go up to 0.2. But now let's look at this one. Okay, if I mark right here, okay, and then I mark right here, now I have 1, 2, 3, 4, 5, let's say 5.5 blocks. What's 4 times 5.5?
I have a question. So if it's gradually getting longer, how do we interpret it? Because it's all
Yes.
different.
So that's what we're going to talk about. That's what I'm doing. You're in the right place, Maria. You're a little ahead of me. So 5.5 is going to be 0.22. Now that's longer than that one. Then I'm going to look at this one, right? And now I've got, I don't know, 5, 6, 7, 8 blocks in between, which is more than this one. And now I have a dropped QRS. I'm missing QRS. So if it's longer drop, what do I have?
Type 1.
Second degree heart block type
Type
1.
Yep. Longer drop, I have Winky Bot. Okay. So for PR interval measurement, you are going to put varies. Because it varies. Okay. Or you could put gradually getting longer. Either of those would be acceptable. I typically just put varies. Is my QR complex within the normal? Looks like it might be 1.5 square, so that would be 0.06. Is that normal?
Yes.
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 Okay. So we've already interpreted this, right? We know it's longer, longer drop. We have Winky Bach, which is second degree type 1. Second degree heart block type 1. Winky Bach. Everybody with me? Kinda? Okay. All right. So let's move on to our next one. All righty. So we have a rate of what?
60.
We have a rate of 60. Is our rhythm regular?
Yes.
You can argue yes or no. I don't care which. You can argue yes, because if you put the QRS in here, it would be pretty regular. Okay. But if somebody wanted to argue no, I couldn't argue with them, because if you measured those out completely, you would find that there might be a little variation in them. So I think you could win either argument. Can you identify your P waves?
Yes.
Yes. What is your PR interval? So we have, oh yeah, entity. We have this one, which looks to be about 1, 2, 3, 4, 4.5. So that'd be 0.18. Then we're going to move to this one. And we're going to mark here. And now I have 1, 2, 3, 4, 5. So now I have about 7.5. And then I'm going to move to this one. And now I have 5. Now I have like 9. And then I dropped. What do I have? My QRS is normal. It looks like it's about 0.10. And my PR interval varies, and it goes longer, drop.
Winky Bach.
Winky Bach, right? Everybody see this? Here's my first was normal, then it got longer, then it got even longer, and then it dropped my beat. Longer drop. We have Winky Bach. Okay. All right, let's look at this one. What do you think's going on here? So let's measure our PR interval. Well, actually, what's our rate? Sorry.
70.
70. Okay, our rate is 70. Is our rhythm regular or irregular?
Irregular.
Irregular.
It is irregular. Yep. Okay. Do we have P waves?
Yes.
And they're
Yes.
upright and they look about the same, right? They look similar to each other.
Yes.
Okay. Do we have, what's our PR interval? Anybody measure it yet? So I'd say about
6.
4.5. What'd you get? Sorry. Somebody was getting ready to talk.
I got a like a 4, a 0.16 maybe.
Okay. And I said 4.5, 0.18. It's the same, nothing, no big difference in that. Okay. So is it the same on all of them?
It looks
No.
the same.
It looks, if you go and measure, it's about the same. It doesn't get longer, right? So if we're just randomly dropping QRSs, what do we have?
Is it second degree type 2?
It is second degree type 2, which is MOBIT. So remember,
Okay.
MOBIT's 2. Okay. And that's the one where we said, if some P's don't get through, then you have a MOBIT's 2. Okay. And some P's just are not getting through to make a QRS. Everybody with me? It's not getting that that PR is not getting longer and longer and longer and dropping. We're just randomly dropping some P waves. So that's what makes it type 2. Everybody with me? Yes, no, maybe so. I'm trying to grab something. My son is going to grab me something to eat. So I'm trying to order it real quick so he can grab it for me. Hold on. All right. All right. Okay. It is a lot of info. Yes, it is, Alicia. It is. And the more you practice these, that's why you had that practice sheet. If you go into the lecture material for week 1, there are strips with practice, and then there's the answer for you guys. So you can go in and practice. Okay. Now, on that practice sheet, it asks, it talks about BiPAP and all that. Don't worry about that. Just, I want you to focus on being able to identify the strip. Okay. Okay. Now we have a rate of what?
30 or 40.
30 or 40, I guess. I would probably give it a 30 because you just barely catch that last one. So, I mean, you could say 30 or 40. Is the rhythm regular?
Yes.
Yes, it is. Except for this dropped beat, it does seem pretty regular. Can you identify your P waves?
Yes.
Yes. What's your PR interval? I think I come up with about 5.
Like a
5.
3.5.
Go ahead. No, what were you going to say? 5 boxes is what I was saying, but go ahead. Lee, what were you going to say?
I don't see 5 boxes. I see maybe like 4, maybe 4.5.
Half.
It's
Okay.
hard to read on this paper though.
I know it is. It is hard to see. And the truth is 4.5, 5. So you're talking about 0.16 to 0.20. Is that normal? Are those, even if we went 0.20?
Yes.
Okay. Right, so it's normal. So, I mean, we don't have to like 0.20 and 0.16 are both within normal for a PR interval. Okay? So I'm not going to worry about that as much. Okay? And then what do we have here? What's
The
missing?
QRS.
A
The
QRS. We have a dropped QRS. Okay? What's the measurement on our QRSs that we have? I could argue 0.10, 0.08, somewhere in there. Yeah, we can. Amber, you asked me about clarifying what's on the exam. Yeah, I'll talk about it. So are we getting, what, does each QRS look about the same?
Yes.
Yes.
Yeah. So what do we have here?
Second degree type 2.
Okay, but
Second degree type 2, which is Mobitz. Winky Bach would be longer drop.
yes, Mobitz.
Yes. So this is Mobitz type 2. Okay. 2 more strips. All right. What's our rate here?
Eddie.
30. Mm-hmm. Are we regular or irregular?
Regular.
Regular. Okay. Do we have P waves?
Yes.
Yes. What's our PR interval?
Some of them, like in the beginning, the P wave is, if that's a P wave, it's way far away.
So yeah, so this is a one where if I measure from here, oops, sorry guys. Okay, if I measure from here, from this P wave to this P wave, that P wave to this P wave, this P wave, you will see that they kind of march out, that they're probably all equal distance from each other, okay? So remember that paper trick I told you where you put your paper against and then you're going to see, you put a mark and then you move your paper down? If you did this on this screen, you will find that all of your P waves are even. And then all of your QRSs are also even, but they're not talking to each other at all. The P waves are doing their thing. The QRSs are doing their thing. What do we have if the P's and the Q's don't talk at all?
That's the third degree heart block.
It is a third degree heart block.
Okay, great.
Yep. So this is our third degree heart block. Because my P's are march out, and then my Q's R's really, QRS march out, but they're not related to each other at all. They're not talking to each other at all. Okay. Everybody see that? You can see where these P waves are just kind of like, you even end up with a P wave at the end of a T, and you end up with a P wave before the T here. So they're definitely doing their own thing. Okay. And our last one. Okay. So What's our rate?
Forty.
40. Okay. Is our rhythm
Yes.
regular?
Yes.
Mm-hmm. Okay. Do we have P waves?
Yes.
Yes. Do we have PR intervals?
Yes.
Okay. I do. So if I measure this PR interval right here, I'm going to come up with, let's see, 1, 2, 3, 3 boxes. So that's 0.12. If I measure this PR interval, I have 1, 2, 3, 4, 5.
We cannot see your measurements though.
Oh, I know. I'm just counting.
Oh, okay.
I'm just counting the boxes in between. That's all I'm doing. So if I'm just counting them, but you will see that that's almost 10 boxes. And now I come to this one. We're missing one here, right? We're also missing a QRS here. We're missing a QRS here. We're missing a QRS here, because that's your P waves. If we measure this QRS or this PRI, you're going to have 5, 6, 7, 8. And then we have another P wave here. So we're missing a QRS. We're missing a QRS. Missing a QRS. So if you go back, and now what I would do when it looks this chaotic and my PR intervals, remember my PR intervals are either going to stay the same and they're prolonged, or they're going to progressively get longer. And you don't have a pattern here of progressively getting longer. They're kind of chaotic and all over the place. So then what I would do is I would take my piece of paper and I would see if my P waves line up. So I would see, does this P wave line up? You know, is it equal distance from this one? And then equal distance from this one? And then equal distance from that? And then there's one in here, you can see it. And then there, and then there. And one at the very end here, and then here. Do you see how they kind of march out? And my QRSs march out, but they march out at a different rate. So if my P's and my Q's are not communicating, what do I have?
And that's a
Okay.
third degree.
It is the third degree. Do you guys see how I kind of, go ahead.
There's no T wave in there. It's
It-
just P waves only.
It's, I'll be honest, it's not the best. I don't think this is lead 2, which I hate to do when you're learning, because lead 2 is what we learn in. But like if you look at this one, this is kind of the T wave. It's not the best to see the T wave. But these P waves all look alike, and that's how you see them march out. And see how there is one in here, but all it did was cause a little blip in that T, because this is QR and this is S, and so your T is kind of coming up. Like I said, I would bet you money this is not a lead 2, looking at it. The other part of this is these QRSs are very wide, okay? See how wide they are? They're from like here, from here to here, okay? And so this tells me that this is probably coming, this rate, the ventricles, is probably coming from the bundle branches or the Purkinje fibers. It's coming from somewhere. So this is going to be our 3rd degree heart block. Okay. All right. So, questions about the test. I don't know how many questions because I haven't made it. So I don't have the answer to that. I don't know how many questions. I still have to make the test. So I think it was Rachel I talked to yesterday. And what I explained is that the topics that are going to be on the test are the topics that we have covered in lecture. So that means your hypertensive crisis and urgency, your congestive heart failure, your coronary artery disease, your myocardial infarction, all the disease processes that we talked about in lecture are going to be on your test. I do not pull all of my questions strictly from the PowerPoint, because the truth is, at this level, you guys have to be able to take knowledge and apply it. Okay? So, what I recommend is that you look at your PowerPoint. If I uploaded the lectures, if you want to listen to lecture again, you can do that. But I would also get in your book, your textbook, read up on any, like if you're a little unclear on a certain part of the disease process or something, get in your book and read about it so that you have a very good understanding of the actual disease process. Because that's what I'm going to be asking you about. If it's a topic we went over in class, it's fair game. Okay? I also recommend, like, if the books aren't helping you and you're still not understanding, get into YouTube, like start YouTubing to help you understand the concepts. You cannot, at this point of the game, guys, you can't memorize. Now, strips are different, and we'll talk about that next. But when we're talking about disease processes, memorizing is not going to help you. You're not going to be able to do it. Your brain's in overload. Think about it. Remember when I was talking about all the strips and I said symptoms? Look, all of these symptoms are very similar because they're all symptoms of poor perfusion. Well, it makes sense. If my heart rate's low, I'm not perfusing well, right? If my heart rate's too fast, my ventricles can't fill to pump out blood, I'm going to show signs of poor perfusion. Either way, I'm not perfusing appropriately. And so the signs and symptoms, that's what you're seeing. You're seeing signs and symptoms of poor perfusion. You guys with me? Okay. I don't ask at this level, I will not ask knowledge-based questions. I won't. Okay. You guys need to be past that because NCLEX is not going to ask you knowledge-based questions. It's not going to do it. So you have to be able to do application and above. All right. So that is like the disease processes. When it comes to your strips, I probably will have a couple of strips that those will be the only knowledge-based questions you have. There will be some strips where you'll have to identify them. And that's why I was getting the measurements, because the measurements are raw. I wasn't getting that technical about the measurements. Okay. But you need to be able to identify the rhythm. Go through and do that methodical thing that we do. You know, what's your rate? Is it regular, irregular? Do you have P waves? What is, if so, what do they look like? Do you have a PR interval? Can you measure it? Does it get, does it stay consistent? Is it longer than it's supposed to be consistently? Or does it get longer drop? Or does it stay consistent and then you just drop a QRS every so often? Or does my P's and my Q's not even match up? Or can I not find a P wave and it's only ventricular? So that's what we need to, that's what I'm talking about when I say that you need to just be able to identify it. I'm not going to have you, shouldn't say that. I don't think that I would have you measure anything out. And even if I had you measure anything out, the truth is, if I came up with 0.2 and you came up with 0.18 or 0.16, I am going to count that as right. If I came up with 0.2 and you came up with 0.5, that's wrong. You understand what I'm saying? Like, to me, those little bits of variation, even nurses who have been doing it for years are going to vary just a little. So that little bit of variation is not going to be what I'm going to get upset about. Okay? Because it will vary. Even between seasoned nurses, sometimes that just the time will vary a little bit. The other thing that I am going to do with strips is that I'm probably going to give you a strip and then I'm going to ask you a priority question, like what would you do first? What treatment would you expect for this? That's why I said you guys got to know. So you may have, because the NCLEX, they're doing a lot of these like the case study type of stuff where I'm going to tell you this is what's going on. I'm going to tell you about your patient and then I'm going to show you a strip and then you're going to be like, I'm going to ask you a question. Like maybe what orders would you expect for this patient? Or what's your first priority for this patient? Or, what symptoms would you expect this patient to have? So you need to know it in all directions like that. Okay. And so I'll be honest with you. Somebody asked me when are the topics going to get sent out? I can send you the topics, but I'm literally going to go through the PowerPoint and I'm going to say, okay, you need to know. Let's see. I'm going to go with the first part, the first disease, and I'm going to say you need to know probably coronary artery disease. Yeah, no. Yep, atherosclerosis. And then I'm going to list coronary artery disease. And then I'm going to list myocardial infarction. And then I'm going to list heart failure. Because that's what's in the PowerPoint. The topics and the diseases listed in the PowerPoint are the disease processes that are going to be tested. Did that answer everybody's questions? Okay. The other thing, just so you guys know, I don't let you see your result. I know you guys are stressed about this test. I get it. I do. Okay. It's getting hard. And these topics are hard. These are hard concepts without a doubt. These are very hard concepts. Okay. I'm not going to minimize that. So I'm also not, remember, I'm not out to trick you. I'm not going to put something there that, and neither does NCLEX. If it's abnormal, it's going to be abnormal. It's not going to be a 100th of a point off. Okay. It's going to be abnormal. I'm not looking to do that type of stuff to you. And neither does NCLEX. What was I going to say? Oh, before I forget, I want you guys to know that you will not get your results at the end of the test. I don't do that because I have to do my item analysis. I have to do my test analysis. And then once I've done my test, my item analysis on my test, and if I'm going to like accept different answers or if I'm going to throw a question out, whatever, I need to do that. And then you guys can have your scores. So, and I will get that done. What's going on? Let me look. I'm going to pull my schedule up right now. So I will tell you when I will have that done by. Okay. I will have that done. Your exam is at 8 a.m. and then we have lecture. So I will have it done by Thursday morning. If I have to stay up late to do it, I will. Okay? I will have your exams in by Thursday morning. Your exam scores in. So I will get that done. I'm even going to put it on my calendar. I'm going to write myself a sticky note. It'll be on my calendar because if it's on my calendar, I swear to God. Exam scores done by Thursday morning. All right. So. All right. Well, the thing is, there's no point in having an anxiety attack until Thursday morning because it's done. There's nothing you can do to change it at that point. And so I give you your score right away. And if it's not right, what does it matter that I gave it to you? If it's not accurate.
Because we would know how bad or how good we did.
But if it's not accurate, you don't know how bad or how good you did if it's not accurate. And that's why I don't give it. Okay. So, like I
Miss
said,
Brandy,
yes.
would you suggest that we use the dynamic quizzes to help us maybe prepare for the test? Like, would it be like around that kind of test question? Like, would it be similar?
So I will tell you that the more NCLEX style questions you do on a topic, the better it's going to help you. Regardless of what my questions are, the more you practice NCLEX style questions, the better you get at them. And there are research studies that show that. There was a study that came out that said that to be successful the first time you take NCLEX, the average nursing student needs to have seen 5,000 plus NCLEX style questions. So the more NCLEX style questions you can do, the better off you will be. But I am very fair, guys. I take a very close look at my tests. And I said, I'm not trying to trick you. Remember to breathe and think it through. Okay? Just breathe and think it through. Read your question at least twice before you answer. You need to know what the question is asking you. And ask yourself that. Say, what is this question asking me? Is it asking me for a priority? Is it asking me like part of the nursing process, what I need to be doing next? So really think, is it asking me for the right answer or the wrong answer? Okay. So breathe. All right. I want to start a respiratory now because we got quite a bit to cover in respiratory too. And I have to get through all of respiratory by the end of Wednesday's lecture because because I'm covering clinicals and labs and stuff next week because I have an instructor off. So next week, Miss Angie is going to be the one who's going to lecture on trauma and what's the other one? Oh, shocks, trauma and shock, that type of stuff. So the topics for week 3 will be by Miss Angie, and she'll write the test for that. So, and you guys have had her before, right? I think you're familiar with how she tests. Yes, no, maybe so. I think you've had her before. Yes, okay, that's what I thought. So you know how she tests, so, but she'll be right because she's the one that did the lecture for it. She is the one that will be writing the test for it. I will be writing the test for cardiac and respiratory. And then we will collaborate to get the final done, and we will both be on to do the review the Monday before. So that Monday, like, lecture is going to be like review. So. All right. And I am doing tutoring tomorrow from 4 to 5. You don't have to jump on exactly at 4, whatever. I stayed on last night until I think like 6:15 or something like that. But my tutoring times, I will just be on. If nobody's in, I have plenty of work to do at my desk. But if you can't make it at the very beginning, if you can make
Is
it in
it
the
this
middle,
link?
whatever, that's fine. Pop on. Yeah. So this week I have, let me pull up my calendar so that I remember. I'll just pull it up on my phone. That's easier right now. So I have tutoring tomorrow from 4 p.m. to 5 p.m. and it's on my rings, the same link we use for lecture. Okay. And then this Thursday, I'm doing tutoring from 11 a.m. to 1 p.m. I know some of you are in clinical, but trying to work around my crazy schedule too. And then I am doing next Tuesday tutoring from 11 a.m. to 1 p.m. because you guys don't have a VSIM. And then I'm doing Thursday from 11 a.m. to 1 p.m. And like I said before, if those times don't work, if those times that I've listed don't work, then just message me or message Miss Angie, and you can try and make another arrangement on another time that works. Okay? So I will do my best to make everything work out to help you guys. So, all right. Thank you. Thank you, Addie. Thank you, babe. All right.
We just got a quote, $225 a cut for the lawn.
Okay.
So I don't know if you're happy with that price.
Yeah, that's fine.
Okay,
Okay.
I'll get him on a schedule, and then he said he would rather do it in person to
Okay.
see the quote and all that.
Okay. Sorry, guys. Okay. So let's start respiratory. Let me share my screen. We're going to start with the respiratory PowerPoint. All right. So just like when I talked about cardiovascular, I'm going to tell you, go back and study up on your normal anatomy and physiology. Has anybody gone and done the crash course AMP? I'm just curious if anybody's had time to pull it up on YouTube.
Yeah, I went on a lesson a little bit, so I had not finished.
Okay, did you like
But
it?
it's- Yes.
Yeah. Okay, I'm glad. I do think it's really good. I think it's a really good, quick, like I said, like the longest video might be 12 minutes and the majority of them sit around 7 to 9. You can watch one while you're waiting to go into the doctor's office or something on your phone. So, I think, and they're good. I think they're a good brush up. So we are going to talk about the respiratory review, COPD, which is chronic obstructive pulmonary disease, acute respiratory distress syndrome, or ARDS, ARDS, acute respiratory failure, which they like to abbreviate ARF, pulmonary artery hypertension, pulmonary embolisms, chest trauma, and artificial airways. Okay. So when we talk about chest trauma, we're going to talk about pneumothorax versus hemothorax. And we're going to talk about chest tubes. And then we're going to talk about intubation. Like when do we intubate? Why do we intubate? What does it involve? And then mechanical ventilation. What that is, what it means to the patient, how it affects them, and then how do we manage it? So that's what we're going to talk about. All right. So the steps of gas exchange, and we've been talking about, like, this shouldn't be new to you. This is information that everybody should be pretty familiar with already. Okay. So ventilation, I'm going to start at ventilation, even though it's just a circle that goes round and round. Okay. Is the act of breathing air in and out of the lungs. When we breathe in, we're bringing in oxygen. And when we breathe out, we're breathing out CO2. Okay. We bring oxygen in, we exhale CO2. Diffusion takes place in the alveoli. Okay. This is where oxygen diffuses from the alveoli and moves into the capillary, and then eventually to the rest of the body. When oxygen is diffusing into the capillaries, CO2 diffuses from the capillaries into the alveoli to be exchanged. So that's what this right here is showing us, okay? That O2 is going to go in and CO2 is going out. And that is the normal diffusion that occurs in the alveoli and the capillary bed. Okay. Remember that you have to have a hemoglobin for oxygen to get bound and move around the body. Okay. Next is that circulation, where the body is going to transport that oxygenated blood to the rest of the body. So if this occurs in the lungs, this capillary is going to bring this oxygenated blood to the left side of the heart, right? Left heart, where it's then going to be pumped to the rest of the body. Okay. Then cells, at the cells, oxygen's going to go into the cells to be used for energy, and CO2 is going to diffuse out of the cell into the capillary bed to then go into the venules, the veins, and back to the heart, right side of the heart, to the lungs. Okay. O2 goes in, CO2 goes out, because it's our waste material. Everybody understand this? You can just give me thumbs up. I'm fine with that. At least I know you're awake. Okay, there we go. All right. Starting to get some response. Okay. So, ABGs. I know you guys have talked about ABGs previous. Okay. Oh, yes. I can let you in on your phone. Sorry. There. You are in. Okay. So this basically the ABG measures the balance of oxygen and carbon dioxide in your blood to see how well your lungs and in retrospect your kidneys are working, because there are two systems. Just like everywhere in the body, you have two competing systems that keep the body within the range that it's supposed to be. Okay. Our heart rate is balanced by our sympathetic and parasympathetic system, right? Including our blood pressure. Our blood sugar is balanced by glucagon and insulin. So, like, our body does this, okay? It takes systems and has them compete against each other to keep it in this narrow area. So when we're talking about pH, the normal pH in the human blood is 7.35 to 7.45. That is where our pH of our blood should be. Okay? Oh, shoot. Hold on. All right, we got to take 5 minutes. I got to go deal with the testing issue. Sorry. Let's just take a quick, like, 5 minutes and I'll be back. Sorry, I'm gonna finish this apple slice. Okay. All right, so your pH is controlled by two systems. The first is the respiratory system, that movement of oxygen and carbon dioxide. Carbon dioxide is what plays a big part in our controlling our pH, because carbon dioxide, it breaks down to an acid. When it's metabolized, it becomes an acid. Okay, and the lungs control that. The normal CO2 level is 35 to 45. Now, opposite of our lungs and CO2 is our kidneys and bicarb. Okay, the kidneys control our bicarbonate, and that system controls a bicarb is a base. Normal bicarb is 22 to 26. So the kidneys control this. This is our metabolic system. Okay. So if the problem is in our lungs that threw our pH off, we call it respiratory acidosis or alkalosis. If the problem is with the metabolic system that throws us off, we call it metabolic acidosis or alkalosis. Okay. I think of pH like a teeter-totter, and we want that teeter-totter to kind of, or that balance to be kind of in this small little range, right? Well, if I add too much CO2, my teeter-totter is going to go like this because I have too much acid, and that makes me acidotic. By the same token, if I start here and I'm balanced and I get rid of bicarb, now this becomes light, the same thing happens. I become acidotic because I don't have enough base. And so my teeter-totter is heavy on my acid side, even though I didn't add any acid. Are you with me? Does everybody understand how there are two ways I can become acidotic? Okay. Vice versa. If I'm even and I add a base, okay, if I add bicarb, then my teeter-totter tilts towards my alkalotic side, okay? I become alkalotic because I added too much base. By the same token, if I'm balanced and I lose CO2, which is my acid, it becomes light on this side and I become alkalotic. So either way will get me into alkalosis. So I always think of it that way, like, okay, what's my teeter-totter doing and why? Okay. So again, our lungs or the respiratory system controls our acid, which is CO2, and our kidneys or metabolic system is what controls our bicarb, which is our base. Okay. So when we're interpreting arterial blood gases, I don't use it. I will do my best to go through this, and I know Miss Angie taught you guys the tic-tac-toe method, correct?
Yes.
Okay.
Yes.
Okay. So, so we'll just follow these steps because it's not the way I do it, but that's okay. We'll do it this way. So we're going to determine our pH. Is our pH an acid, an alkalotic, or alkaline, or normal? Okay. Then you're going to look at your CO2 and see if it's high or low. And then your bicarb, is it high or low? And that's how you interpret your ABG, either respiratory or metabolic, alkalosis or acidosis. Okay. So that's your basic ABG. So the body, we're going to talk about what goes on in the body when we're in the different states. But before we do that, I want to talk about how the body functions overall as a unit. The body always wants our numbers to be within the normal limits, right? That narrow window that we have. And it doesn't care how we get there. Amber, did you have a question? Oh, okay. So the body doesn't care how we get there. It only cares about where the numbers are. So I say, but the body's like Goldilocks. It doesn't want it too much. It doesn't want too little. It wants it to be just right. And it doesn't care how we get it just right. All it cares about is where we get it to. So when we're talking about pH, the only thing the body cares about is that the pH is between 7.35 and 7.45. It doesn't care how we get there. Okay? It doesn't care. It just wants that pH in that range. So, respiratory acidosis occurs when our CO2 goes up. Our CO2 is an acid. Okay, so it's going to be greater than 45. That makes our pH go down because the lower the pH, the more acidic. So if we add acid, we drop our pH below 7.35. Okay, so if we are in respiratory acidosis, our CO2 is greater than 45 and our pH is less than 7.35. So what can cause this? Well, if our CO2 is going up, it's because we can't blow it off. We can't get rid of our CO2. So anything that causes respiratory depression, so if I'm breathing less, I'm not getting rid of my CO2, I'm going to start becoming acidotic, and it would be a respiratory cause. Okay? Things that can do this are drugs. So opioids, because it drops the heart rate, sedatives, not heart rate, respiratory rate, because it drops the respiratory rate. Same thing with sedatives and anesthesia, right? We breathe less. And if we're breathing less, and not as deep a lot of times, we're holding on to CO2. Patients who have increased intracranial pressure. Did you guys cover neuro last time?
Yes,
And did you cover increased intracranial pressure?
yes.
Okay, good. Okay, so if you have increased intracranial pressure, this affects your drive to breathe and can cause respiratory acidosis. The other one is sleep apnea, because what happens during sleep apnea? They stop breathing. So again, we're holding onto CO2. Okay. Also, anything that causes impaired gas exchange. So any type of disease process that impairs our ability to exchange gas at that alveoli level, can't talk today, okay? So remember, in that capillary and the alveoli, it brings oxygen in and gets rid of CO2. Anything that affects that or impairs that, and particularly impairs it, is going to increase our CO2. This includes things like COPD, PNE, which I think is pneumonia. I don't even know. I hate sometimes they use terms. I don't know. Anyways, but pneumonias will. Chest wall trauma and PEs. So PEs are blood clots that prevent blood from getting to the alveoli, and that can't have gas exchange if you can't get blood there. Chest wall trauma can be a couple of reasons. One, the lung itself can get damaged. Two, has anybody ever had a broken rib? Anybody broke a rib? Know somebody who broke a rib? No. Okay. So rib fractures are painful, and it's really painful to breathe. And to take a deep breath is really painful. And so patients who have broken ribs and stuff have a tendency to take really shallow breaths because of the pain. But that means they hold on to CO2. So we have to really encourage them and make sure they understand that they need to be taking those deep breaths. Okay. What is a tool that we give patients to help them with their gas exchange or breathing?
Incentive spirometer.
Yep, incentive spirometer. Yep, good job. Okay. That incentive spirometer it really does work. It really is a big deal. And I know we kind of blow it off or we think it's silly or whatever, but it really does work. And I learned that from personal experience, unfortunately. I had the original COVID before the vaccine came out, and I was very sick. I was in the hospital for a month. And when I started my incentive spirometer, after one, I was on 45 liters of oxygen for, I don't know, 10 days or something. It was quite a while. But when I started, yes, I did say 45. That is correct. Yeah. I've seen my CT. It was almost completely whited out. So I had a pretty significant pneumonia. So, but when I started my incentive spirometer, thank you. I'm glad I'm okay now too. I could barely get 50 on my incentive spirometer. And the nurses were great. They really were like, you got to do this, like, let's keep working on it. Let's keep working on it. And I did get back to a point where it was better. I could get to like 300, 400, which is a big improvement considering I could barely get to 50 when I started. So it really does make a difference, and it seems silly, but it really, really does help patients, even if they don't see it. Okay. So what are some symptoms of respiratory acidosis? Well, altered level of consciousness, right? If we have a buildup of CO2, we also probably aren't exchanging gas or oxygen as well. And so that can really decrease our level of consciousness or alter it. Going to have a decreased respiratory rate because of that respiratory depression, or decreased BP. Hypoxia. Okay, so you're going to have hypoxia because remember I said if we're not moving CO2, we're also not moving oxygen. Okay. And then you can have dysrhythmias from that lack of oxygen, really is what it comes down to. Okay. So, and then, so we'll talk about compensation. The treatment is to administer oxygen, suction any secretions, because it's hard to exchange gas through purulent material, fluid. Remember, we talked about that with pulmonary edema. The same goes when you have an infection and there's a lot of consolidation or junk in their lungs, secretions, mucus. Okay. Turn, cough, deep breathe. So getting your patients to actually move in the bed. If they've had surgery, they don't want to take a deep breath a lot of times, especially like abdominal surgery or chest surgery, but they have to. And so teaching them how to splint. Anybody here, has anybody been to like seen somebody post open heart? But the thing that they wear around there,
Yeah.
and so
My daughter had 2 open heart surgeries, so
yes,
I've
and
seen
so
it.
you know that yes, we want them to cough and deep breathe, but they also have to protect that. So they have a thing that it goes around. It's just like a strap that goes around and it has 2 handles, and they can hold those handles together to like cough or help with their deep breathe to help kind of splint that. You can do the same thing with like a pillow. A lot of places post open heart surgery patients, they get like a little heart pillow that they can use to like splint their chest when they cough. You can use blankets to do it, rolled up blankets. You just want to help them splint when they cough so it doesn't hurt as much. And take a deep breath. Antibiotics, if needed, if there's an infection, then we need to get the antibiotics in. Okay, so briefly, this is going to talk about compensation, and we're going to get more into that. Then that's why I was telling you about the body doesn't care how you get to that 7.35 to 7.45. It only wants you there. Okay. So to compensate for this acidosis, hydrogen ions will move into the cells to lower the pH, but that causes potassium to leave the cells and enter the blood, causing hyperkalemia. Okay. And so your potassium is going to be high, and that's why that's why they're at risk for dysrhythmias. Okay. So long time ago taught us saying, and that's K gets high on acid. So your potassium is going to be high when you're in acidosis. So we have to keep a close eye on that. And that's one of the compensatory mechanisms. Oh, I went the wrong way. No, yeah, I did. Sorry. I went the wrong way. All right. Respiratory alkalosis. So this is where the CO2 goes down. So we're breathing off CO2 and it's going to be less than 35. So the pH goes up. So it'll be greater than 7.45. Okay. So we're blowing off a lot of CO2. We're getting rid of it. So what can cause respiratory alkalosis? Anything that causes hyperventilation. I'm going to have rapid deep breaths. I'm going to get rid of my CO2. Okay. Anxiety, panic attacks, right? Pain. Think about if you've been in severe pain, you have your respiratory rate has a tendency to be up. Fevers. Our metabolic, everything speeds up when we have fevers. Asthma, okay? Patients who have asthma, they trap air, they feel like they can't get rid of it, and their respiratory rate will go up. Pulmonary embolism. Again, respiratory rate can go up. Aspirin toxicity. This is a weird one. So when we have aspirin toxicity, what occurs in the body of the breakdown of that aspirin makes the cells at a cellular level, the cells feel like they are starving for oxygen. It causes the cells to feel hypoxic, which then causes patients to increase their respiratory rate and leads to a hyperventilation. It's a very bizarre thing that happens in aspirin toxicity. And then mechanical overventilation. So this is where we're bagging a patient, right? They're intubated and they were in surgery, whatever, we're bagging them and we do it too much. or the vent is set at too high of a respiratory rate. And so we end up blowing off more CO2 than we want. Okay. And that's what they mean by mechanical overventilation. So, what are some symptoms? Increased respiratory rate and depth. So, deep, rapid breaths, increased heart rate, confusion, dysrhythmias. Okay. So, this time your dysrhythmias are caused by hypokalemia, because to compensate for the alkalosis, hydrogen ions move out of the cells to increase pH. That says acidosis, but it's supposed to say alkalosis, okay? Hydrogen ions move out of the cells to increase pH, causing potassium to enter and leave the blood, causing hypokalemia. So, our pH messes with our potassium levels, and our potassium levels mess with our heart. Okay. And that's how you can end up with dysrhythmias from pH imbalances. So what's our treatment going to be? Well, we're going to use breathing techniques to slow down their breathing. This is why somebody who's having a panic attack, we give them a brown paper bag to breathe into, because when they do that, they're breathing back their own CO2. That's what's going on, okay? They actually breathe back their own CO2 to bring that CO2 level back up. Or we can have them do like, I do the look at me. I get them to look at me, and then if you get your respiratory rate with the kind of close to theirs, and then you're like, okay, and you start bringing your breathing down, they will bring their breathing down with you if you can get them to focus on you. Okay. We may use some supplemental oxygen if they feel like they can't breathe. Okay. Anti-anxiety medications, because if it's anxiety causing it, we need to deal with the anxiety. Sorry, and analgesics for pain or fever. If it's pain or fever that's causing an issue, then we treat the underlying cause. Okay, any questions about respiratory alkalosis? All right, now we're going to talk about metabolic acidosis. So bicarb is our base. If bicarb drops, if it goes below 22, remember that's my teeter-totter, and now I have less bicarb, is going to tip into acidosis. Okay? So if my bicarb is below 22, my pH is going to go down below 7.35. So what can cause metabolic acidosis? It's a lot of things, okay? Anything that causes increased acid production. So this is things like malnutrition, where they start breaking down fats, which the breakdown of fats causes excess ketones. DKA, okay, where again you start breaking down acid, you start breaking down fats and stuff, you'll get ketones and they build up in the body. The bicarb decreases. Sepsis, because lactic acid increases when patients are septic. Alcoholism. Well, that has to do with not only the alcohol, but the malnutrition also. Okay. Anything that causes acid excretion, like, or decreased acid excretion, like renal failure. If the kidneys are unable to excrete the waste, then you have buildup of acids and bicarb reabsorption. So, and decreased bicarb absorption. So you hold on to the acids and you don't have as much bicarb. Okay? Anything that causes excess bicarb loss. So severe diarrhea. Remember, bicarbs comes out of your base. Or if it comes out your the bad word for your bottom is then it's acidosis. So okay. So severe diarrhea can cause us to lose bicarb and put us in metabolic acidosis. So some symptoms. Kussmaul's respirations. So those are the rapid, deep breaths. Rapid, deep breaths. And then when I say rapid, I'm talking about patients that are in DKA. You see this a lot with DKA, right? You guys have learned about DKA already. So you know one of the signs of DKA is Kussmaul respirations. These patients will have respiratory rates in the 30s. Okay? Rapid, deep breaths. Decreased blood pressure, confusion, hypoxia because they're breathing off, they're trying to rapidly breathe to try and bring the acids down. And then hyperkalemia, because I said K gets high on acid. If you are in an acidotic state, you are going to be hyperkalemic. If you are in an alkalotic state, you will have a tendency to be hypokalemic. Okay. Treatment. Well, we're going to correct any electrolyte imbalance, especially we need to deal with the potassium levels potentially. We are going to put these patients on seizure precautions. I'm supposed to say precautions. And monitor respiratory status. So I'm going to I'll tell you a story. So I worked for ProMedica, which is a hospital system here in the Toledo area. And when I worked for them, I worked in what was called an electronic ICU. And they do have them in other places. ProMedica doesn't have theirs anymore. But basically, we monitored every ICU in the ProMedica system. We could camera in and see the patients live. We also saw their charting live. We could co-sign drips. We had their monitors, which we could see live, just like the nurses at the station. We had access to all their labs. We had access to everything about the patient. It was called a doc in the box. We had a doc with us because we sat in an office. I had 6 computer screens in front of me, each of us did. And so we sat in this office area and our doctors would be there. Our doctors could run a code if needed. Now, you think like in a big hospital, that's not an issue, but in your small rural hospitals where the only physician on in the middle of the night is the ER doc, having a critical care doctor that can run a code is a big deal, right? And so they can give them orders and everything right over the camera in real time. So I was working in the electronic ICU and there was a patient coming from ER going into one of the ICUs that I was monitoring that day. And I asked the ICU nurse, I said, are you guys this was a new onset patient, new onset diabetes patient who was in DKA and had a pH of like 7. I think the last one I saw before they came to ICU was like 7.02 or something. I mean, it was 7.0 something. We're getting to where it's not so conducive to life, okay? So I asked the nurse that was taking the patient, I said, are you guys setting up for intubation? And she said, why would we set up for intubation? The patient's breathing. Yeah, the patient's breathing at like 36, 38. How long do you think you could breathe at a respiratory rate of 36 or 38? Okay, eventually you're going to give out. You're not going to have the ability to maintain that respiratory rate. And sure enough, probably, I want to say within an hour of that patient coming on the unit, they had to call a code because the patient went into respiratory arrest because they couldn't maintain a respiratory rate that high. And so part of being a good nurse is knowing what's going to happen, what potentially is going to happen, and how do I mitigate that? How do I reduce that risk for my patient? Now, either way, the patient ended up intubated. Okay, I wasn't going to change that, but I can intubate where I have time. I can get respiratory here. Okay, I can get everybody in place. I can get my patient sedated. I can have all my equipment here and everything set up and everything's calm, cool, and collected, right? Or I can intubate my patient after they go into respiratory rest and now we're in a medical emergency. It's much better to intubate your patient the first way, okay? So, and luckily I do understand that because my oldest son is a diabetic and he's a type 1 diabetic that was diagnosed in his 20s. And he went into DKA. And when the critical care doc came down to talk to us, he said, hey, you know, because he was on BiPAP and his respiratory rate was still like 36 and his pH was like 7.1 something. And the critical care doc came down and he said, I understand your nurse, because we were in the ER I had worked at, so they knew me. And I said, yeah, I worked here. He goes, yeah, I heard. He goes, look, I really, really think we should intubate your son. And I said, absolutely, let's do it now. And he was like, oh, okay, cool. And that's what we did, because I knew what was going to happen if he didn't get intubated. And again, I'd much rather that be done in a controlled setting than an emergent setting. Okay. So that's why we monitor that respiratory status, because your patient is only going to be able to keep up those Kussmaul respirations up to a point, and then they're going to stop breathing. Okay. Any questions about that? All right. Last one is metabolic alkalosis. So this is where your bicarb goes up, okay? Your bicarb goes up, so the bicarb gets heavy, and your pH goes up. So your bicarb is going to be greater than 26, and your pH is going to be greater than 7.45. What can cause this? Excessive loss of acid. So excessive loss of base is through the diarrhea. Excessive loss of acid is through vomiting or GI suctioning. So when we put an NG tube down and then we have that to like low intermittent wall suction all the time, which we have to do sometimes. Patient has a bowel obstruction, those type of things. We really don't have a choice. We have to do that, but we have to know that because we're doing this, my patient is at an increased risk for a pH imbalance. Okay. Again, knowing what's coming. Anything that causes excessive bicarbonate. So excessive bicarbonate administration, that means we were trying to correct probably an acidosis. We gave too much bicarb and now we're in an alkalosis state. Excessive consumption of alkaline content. So this is baking soda, milk, and antacids. Antacids are the most common perpetrator of this. People, patients don't want to go to the doctor and their heartburn's bad and they're like going through a bottle of Tums a day or Rolaids, whatever. That's bicarb. It's a base. And so when they take an excessive amount, they are going to increase their bicarb. Hyperaldosteronism. So this is that causes that sodium hydrogen exchange in the kidneys. And when hydrogen goes down, bicarb goes up. Lots of things have inverse relations to each other. And then loop diuretics, too much. It can cause the kidneys to release hydrogen through the urine. And then that bicarb, hydrogen goes down, bicarb goes up. Okay. So these are the things that can cause metabolic alkalosis. Symptoms are going to be decreased respiratory rate, hypokalemia, because remember, if I'm in alkalosis, my potassium is low. If I am in if I'm in acidosis, my potassium is high. Okay. When my potassium is low, my calcium is low. And that's why you're going to see the chefsocks and your tetany, irritability, lethargy, those type of things, and potential dysrhythmias. Treatment. If they're vomiting, we're going to give antiemetics. We're going to give electrolyte replacement, IV fluids, so that they're not dehydrated. And we can give a diuretic called Diamox, and that diuretic promotes the loss of basically gets the kidneys to excrete bicarb through the urine. Okay, that's what it does. So we're pulling all that extra bicarb off. So let me ask you a question. Which state do you think is most common, an acidosis or an alkalosis? Which do we see most often? Whether it's respiratory or metabolic. Do you think
I think acidosis.
yes, it is acidosis, is much more common. Not that you don't ever see alkalosis, but acidosis is much more common. Typically, if we're dealing with an acid-base imbalance, it is usually acidosis, okay? Oh, Bridget. All right. Let me see where we're at. Does this talk about compensation? I'm trying to remember if we talk about compensation later in this. Yeah, we do. Okay. I think we do. So I don't know if I want to actually start ARDS right now because it's kind of a complicated concept. And I think you guys kind of have a little bit of overload anyway. So we didn't take like that last break or whatever. So I'm just gonna, are you guys okay if we call it for today?
Yes, thank you.
Okay, sounds good. All right. And remember, I do have tutoring tomorrow from 4 to 5. If you, if those times don't work, and you just jump on this link, if those times don't work, reach out to me, please. Okay. All right. You guys are free to go.
Quick question, Miss Brandy, while everyone is jumping off. Sorry.
No, you're
Um, I thought that most of our exam was going to come from like what you spoke about and taught in class and the PowerPoints.
Yes.
I did read over the chapters, but just I don't memorize things like in length like that. So if you have a basic understanding of the PowerPoints and the disease process and cause and effect, is that basically what you're looking for in treatment from
Yes.
us?
Yes. And
Okay.
I'm not saying you have to read your textbook from like cover to cover. And I was explaining to Rachel on Sunday that textbooks are not meant to be read like a fiction book. And so textbooks are really to go in there, like if there's a part of something you don't understand, to get more detail, to maybe help you put the picture together. But if you've like glanced through or you feel like you have a good understanding of what it is, and again, like what I talk about, like, can you figure out what's going to happen? Can you figure out what you should be doing? Those are the type of things that I'm looking for from you guys, because that's what NCLEX is going to test you guys on. Do you understand this well enough to be safe, to mitigate risk?
Okay, thank you. That's what I thought you were meaning, but then I was like, I can't memorize these chapters, so.
Oh, no. I'm not asking you to memorize chapters. Nope.
Okay. If I try to come up with some sample questions, could I email them to you for some feedback on them?
Yeah.
Okay, thank you.
Yep. Anybody else have any questions? Mhm. No, you guys are free to go. Don't feel like you have to stay on. I'm not like you're gonna have your attendance. I'm not gonna dock anything. So
Thank you.
you're welcome. Have a good one.
Thank you.
We're done for the day. If you
Can
are
I
left off.
have just a minute with you after this?
Mhm. Yeah.
When I'm trying to switch my speaker, my speaker's messed up. Can you hear me?
Yes, I can. Yes.
My headphone just died. So, what day was that, babe? Friday? Friday morning? About 3 a.m. Friday.
Uh-huh.
Was having real bad heartburn. So I
Okay.
went to take a Protonics. I accidentally took a Prazosin
Okay.
for night terrors. I'm 100% disabled for I have night terrors, VA. But I don't take the med. I don't like the way it makes me feel. I had a
Right.
violent reaction. I ended up in the ER. My troponin was a 25. I passed out, hit my head. Today I feel good today, but I was late on some of my stuff. If I submit screenshots of my chart to you, will you give me till tonight to turn some of my stuff in? Saying I was like in the ER.
What's
I was
that?
having some issues.
Yeah. If you screenshot me, I can.
Okay. All right. I tried to. I was so lightheaded all weekend. Like, I don't know. It kind of messed me up.
Okay.
All right. Yeah, I'll screenshot it. I'll send it in an email.
Okay.
Unfortunately, my son is crazy and destroyed paperwork. But so I just screenshot my chart and send it to you.
Okay,
All right, thank
no
you.
problem. Yep.